Yes, sir.
So again, I would reiterate what Dr. James Strasser already said. It's really, very heartwarming and amazing always that on a Saturday afternoon we have a huge attendance in this lecture series, which I must, credit the all the attendees who are there. And in spite of your schedule, working throughout the week and even on Saturdays, it is there. You have it in you to attend this, to be able to, improve your skills and your knowledge, and also work towards the improvement of the health systems and also the health services of our country. Thank you very much for this. And I also would like to commend the my QPS team led by Dr. James Srivastava sir and DSPRUD Dr. Sangeeta for continuously organizing these. There are Saturdays generally I either work from home or go to Ministry in Environment Bhavan, or I am in office. It's by 2:30. I sometimes many times feel that okay, no, let me take a break and do some other work. But then whenever this event is there, I try to be there. I missed one or two in between when I was traveling, and I couldn't get the connection that time. But it's really always very happy to be here with you all. Um, the experts will be talking about this important topic, but I thought I would share some thoughts that we all know the importance of this topic as such, nutritional deficiency in children, and it's an intergenerational event. It's not only that we should be looking only after nutrition deficiency of children only. There are a lot of issues associated with this. Social determinants of health also are one of the reasons for this as such. So according to WHO, also as we know that 45% of deaths in children aged under 5 are linked to undernutrition. And globally, in low-income countries, we all know that iodine, iron, vitamin A are considered vital micronutrients for health. And the numbers, of course, from the NFHS, we all know. But a worldwide assessment estimated that there's a large number of households that did not have iodized salt excess, and nearly 190 million children of preschool age and 19.19 million pregnant women were deficient in vitamin A, with more than 2 million people deficient in some of the other micronutrients as such. So in India, the most common nutrient deficiencies, I think we must first look at protein before going to micronutrients. And I'll come to it that why I give more importance to protein and other as the wholesome food rather than looking only at micronutrients as such. But when we talk of micronutrients, the iron, folic acid, vitamin B12, vitamin D, vitamin A, and of course iodine. But at the same time, we are in a stage of nutrition transition with the underweight as well as overweight both being seen. And the outcome of this we all know: stunting and wasting, all those which you all are aware. But there are many subtle signs like general weakness and difficulties in concentration or scholastic achievements, or even the sports and all over this, and some kind of other the effect on skin or hair or even other body functions could also be sign of poor nutrition as such. So that's why all of you working in field should be aware of those signs instead of only, and along with the signs of a large major deficiency as such. The factors as such, as already mentioned earlier, social determinants of health is the mother's education, the parental education, mother education, the health and nutrition of the women, the access to public services and household amenities, and also use of sanitation facilities. The NFHS clearly showed from 1516 to 1920 there was some issues with the stunting and wasting, and few of these states also showed an increase in the number of these, which is an area of concern as such. And we should also know, all of us in this webinar, I think the experts would also cover that, so I'm not going to read that. What does stunting mean? What does wasting mean? What does low weight for height, and underweight? What is low weight for age? So all these subtle differences should all be known, which is a sign of chronic nutrient deficiency, which is a sign of acute nutrient deficiencies. I think that will be covered by the experts, so I'm not going into that domain. But from a public health point of view, I think it is essential to understand that the effect of social determinants of health improvement uh, and their effect on the improved indicators of health there's a lag period, which may be several years as such. And we have seen tremendous progress in a country with almost all villages now with open defecation free under Swachh Bharat Abhiyan, Swachh Sarvatra, there are schemes like that. There's a Har Ghar Jal Nal Jal. That's the kind of, on a Jal Jeevan mission. There's single village schemes, there are multi-village schemes, and I've seen on ground also where it is now potable water is being given to people, is being provided to people, which is also, and along with the increased availability also, the quantity as well as quality. So all these improvements will show effect subsequently after a few years from now in the improved indicators. But at the same time, we can't just wait for that, and it is extremely important that we address this issue now only as such. So the from my own personal view is the home cooked, nutritious, wholesome food, a balanced diet is most important rather than only addressing only the micronutrients and all. So that's where wherever you are, kitchen gardens and local produce, locally available fruit and vegetables, and also sitting with the families and discussing with them about the intake of the proteins, carbohydrate, fats, minerals and all will also obviously come into that automatically as such when we talk of food diversification and address some dietary preferences or dietary fads as such as we say. So once you do that, you don't have to go into other kind of issues like supplementation or fortification and all that. Also, of course, the government's policies are there for a few of those, but what instead we can't be having for everything. So it's better to have that approach which would pay dividends in long term instead of looking only microscopically at micronutrients. I don't know whether experts would fully agree with me or not, but we will be very happy to understand their viewpoint and also look at what would they be presenting. So we'll have 3 lectures subsequently now: nutritional deficiencies in children, some myths and facts by Dr. Sangeeta Sharma, followed by nutritional disorders in children by Dr. A.P. Dubey, who's been former director professor and head department of pediatrics, MAMC and Ellen Hospital, New Delhi, and common nutritional deficiencies in children by Dr. Puneet Kaur Sahi, who is an associate professor in department of pediatrics, MAMC, and Lok Nayak Hospital, New Delhi. So I wish all the participants happy learning, and I'm sure and I'm aware that participants are from different disciplines, and it includes the doctors, nurses, the allied and other healthcare workforce, and so it's a varied background. So I'm sure you're definitely going to gain as you have been doing since in the previous 19 lectures till now in this series as such. So once again, thank you very much for all of you for joining in today for this learning experience. And thanks to all the experts who would now be discussing and sharing your views. Please feel free. I would request all the participants that you must ask questions. Keep on writing in the chat box. There are team members from QPS who will be, noting those, and they will try to address those either through experts or subsequently because your interaction, I think, is more important than just listening to the 3 talks as such. So with this, I'll stop here. Thank you very much. Wish you all the very best.
Thank you so much, sir, for enlightening us on the importance of nutrients. Now I request Dr. Sangeeta Sharma, ma'am, Professor IHBS and President DSPRUD, to take session on nutritional disorders in children, myths and facts. Over to you, ma'am.
Thank you, Siddhi. Thank you, Dr. Kotwal and Dr. Srivastava, for hosting these very important webinars, and we see the attendance here that shows that is the testament of the continued interest and the demand, and I hope people are getting benefited. This is one step ahead in the implementation of the standard treatment guidelines, and without your support, NHSRC support, it wouldn't have been possible. So it means a lot to us as well. Together we can achieve more of reaching the people sitting sitting at the distant remote facilities who otherwise do not have any other access to continuing medical education. Now today we have a very important topic. I'll be taking this topic from the medication safety point of view. What are the concerns that we have? Because regarding undernutrition or malnutrition or micro deficiencies, we have two experts with us. But as we know that this is very important topic for us because of the cognitive, emotional, and physical development of the child. All the micro as well as macronutrients are important for the physical growth of the children. Brain development, cognitive function is related to that. Memory, concentration, problem solving skills, all these are important from brain health point of view. And that too, this is very important that early in life that balance is achieved, and so that they don't suffer on these. And also these nutrients help in developing, supporting the immune system, especially vitamin C, D, zinc, and provide probiotics because they help children in fighting infections which are very common in the children. So immune system, if they have a better immune system, infections are lesser. They can engage in physical activity, sports, and play, which is very, very important for their overall growth and sustained energy and support and overall health. Emotional well-being is also very important, and this is also again related with the nutrition. It is related with the children's mood, behavior, and emotional well-being, especially omega-3 fatty acids and complex carbohydrates. They have been reported to support positive moods, behavior, and emotional well-being in children. And of course, last but not the least, establishing healthy eating habits in children. This which goes long way to adulthood. We see a lot of health problems, non-communicable health issues in adults as well. And many of these stem from because of the faulty eating habits in the childhood. And as we know, there are common nutrition disorders, malnutrition, both extremes. We are witnessing both extremes, undernutrition as well as overnutrition in this time. And of course, the most prevalent has been iron deficiency anemia, vitamin D, A deficiencies, and some food allergies and intolerances are also seen, which are mixed with, people don't understand, they underestimate the prevalence of these, and because of these there are problems with the nutrition in children. So spectrum, as you know, is ranging from acute malnutrition, wasting, to stunting and deficiencies, obesity, and overweight. So we need to avoid both of these. And as I said, food allergies and intolerance also may interfere with the nutrition. Many a times we don't understand these terms properly. Food allergies are reaction to the food, immune system's reaction to the food, which can result into skin reactions, GI symptoms, respiratory symptoms, and sometimes anaphylaxis if it is very severe. Whereas food intolerances are, something to do with the digestive system, where there is lactose intolerance or gluten intolerance is there. So because of that, the patient may be having some problem on eating certain types of food. So, and there is a prevalent myth that some of these allergies are not very common, but in fact they are common, quite common, and the reaction may range from mild to severe. Severe reactions have been reported with eggs, peanuts, tree nuts, almond, cashew, walnut, like that. So one has to be, why am I mentioning here is that one has to be looking for it to timely diagnosis. And in case of food allergy, best is to avoid such foods and intolerances that you have to address accordingly. You have to modify the diet accordingly. Then besides that, there are many other myths, whether the children will eat on their own, when sometimes they are overfed, some sometimes are underfed because many of us also believe that they will ask for it when they are hungry. Supplements can compensate for a poor diet. More and more reliance has been on these things. Sometimes we offer sweets as rewards, and we think that this is harmless. Over nutrition or overweight, obesity largely is because of excess consumption of fast foods and these sugars in the. So like this, there are many myths are there. There are facts which related we need to know. IAP, Indian Academy of Pediatrics, Dr. Dubey has been very, very active member of Indian Academy of Pediatrics. They have prepared these guidelines for parental guidance on malnutrition. I would urge you all to go through this. This is a very nicely prepared guideline for parents, addressing all these myths and facts as far as these food habits are related. Now, also, you must be also, reading in the newspapers. There is a lot of question about the misleading ads, particularly Bonvita has been under the scanner because of its excessive sugar content, and the way it has been promoted, that as a stand alone, that this will take care of all the nutrition problem, and the growing change in the food habits, more and more consumption of fast food, complex is these sugars, which is leading to these problems. So we need to be careful about this. Again, IAP has developed guidelines, and they have come up with definitive. They have analyzed the data and come up with the harmful effects of some of the junk foods. So they call it junks food, J for junk food, which are not to be used, which are lacking in micronutrients and minerals, and ultra processed foods, because they are energy dense, low nutrient density food, powdered milk supplements. They are poor foods for children and foods for minimum nutrition value, and nutritionally inappropriate food. This also includes homemade foods that can also be qualified as nutritionally inappropriate if they are prepared in recycled oil or contain high amount of sugar, fat, or salt. And of course, C stands for caffeinated, colored, or carbonated beverages, and sugar, S for sugar sweetened beverages. So they have worked out the adverse effect of these junk food, and they have also come up with the consumption frequency which is allowable, permissible. For example, fast food, they said not more than 2 times per week, and sweetened beverages not more than 4 to 6 per week, and caffeinated drinks certainly not in the children, and if consumed more than 4 per week, these caffeinated drinks can lead to cardiac arrhythmia, sleep disturbances in adolescents, and psychiatric disturbances in the adolescents. And definitely the very well known, which is there is a strong evidence to support that it can lead to overweight, obesity, cardiometabolic risk, risk of developing type 2 diabetes in adulthood, high blood pressure, behavioral symptoms, and dental caries. Now, coming to a very important point, the iron deficiency anemia, the medication safety related issues. We have a lot of preparations of iron which are available in market, ferrous sulfate, ferrous fumarate, maltopher, ferric ammonium citrate. Various salts are available, but not all iron preparations are equal. They vary in the form of elemental iron that they have, and it is different for different salts of iron. And one thing that disturbs me, I have been working in this area and promoting rational use of drugs for many years now. Many of us write, whenever we get a patient of iron deficiency anemia, and we write Dex Orange. And I think if you look at the top selling, the brands of iron, and even otherwise, few years back, Dex Orange was one of the top selling products in India. And this is the most expensive and the most dubious preparation, according to me, that we have, and which is being prescribed for iron deficiency anemia. And many a times, these patients who are malnourished, they are also given these Dex Orange, these hematinics. My question always had been that they are not able to afford a square meal for a child, and how would they afford an expensive hematinic agent like Dex Orange, which otherwise also has a very dubious efficacies as far as increase in hemoglobin and iron content in this preparation. So I think one take-home message that I want you to, because most of us are prescribing iron preparations, keep this in mind, that there are various salts are available. Not all of them are equivalent. You have to look at the elemental iron content in each of these and accordingly prescribe. And mind you, 1 milligram iron is not equal to 1 milligram elemental iron. So that is why it is very important to look at this. Now, okay, I will ask you, all of you, to look at this prescription. This is a real life prescription. I got this a few years back from a hospital. And just look at, try to find out what is wrong with this prescription. It says the patient is a 5-year-old child. Diagnosis is nutritional anemia, and the advice has been syrup tonoferon, 1 TSF, BD, and tablet folic acid, half tablet OD, and tablet BC, 1 OD. The child's weight is 16 kg. You can write in the chat box. I can see. Duration not mentioned, but presumably this prescription was dispensed for 1 month. Dose not written, very good. Dose is missing. Below 5 years, syrup should have been given. Okay, tonoferon syrup has been prescribed. When you say dose is not written, what do you mean by that? When you say, okay, ml, okay, instead of a teaspoon, ml should have been strength. Okay, very good, very good. Why this prescription is important, and I particularly discussing this here, is because, as you know, tonoferon, there are different formulations of tonoferon with the name tonoferon are available in the market. You'll see tonoferon drops are there, tonoferon pediatric syrup is there, and this is another preparation of tonoferon. And if you look at the elemental iron content in these, this is a combination. Drops is a combination of colloidal iron, lysine, folic acid, vitamin B12, and there is iron is about 200. Elemental iron is 25 milligram, and in this pediatric is 80 milligram, and in this preparation colloidal iron equivalent to elemental iron is 250 milligram. Now, if you again go back to this prescription, if considering 1 TSF as 5 ml, how much iron would be given to this child? You can write in the chat box how much iron will be given to, according to this prescription here. What is the dose of normal dose of iron in children? See, each of you are saying different, total dose, which will come out of this calculation here. Normal dose is 3 to 5 milligram per kg body weight of the child. And if you do not see, the point I'm trying to make here is not all brands are equivalent. Not one thing is that not all brands are equivalent. There is a difference in the dose strength of different brand. Otherwise also, if you look at thyroxine, L-thyroxine, this will be available in 25 microgram, 50 microgram, 100 micrograms. So all of them are thyroxine, but they differ. Amoxicillin, different dosage forms are there. So that we understand, but within a brand itself, there may also be a lot of variation in the content. And one perfect example of this is tonopherol. So whenever you are prescribing for children, there are two things that we need to be very, very careful is about that we must write the strength. What is the strength of the preparation that we are prescribing? So accordingly, then we would know how much total dose is going. According to this child's weight and the tonopherol syrup. Suppose if this child gets this preparation, there would be iron overload for this patient. So always write strength. And prescribing these medicines by TSF is again not a very good practice, because size of the spoon may vary depending on the different households. It may vary from 3 ml to 7 ml. So you can imagine the difference in the dosage if you prescribe it in the form of a teaspoonful. So always, with iron preparation, I would request you all to, especially in children, I think Dr. Dubey is here. He can further elaborate on this. All medicines, whenever you are prescribing, must write the strength and the exact ml that you want to prescribe. And whenever you have an amount less than 2.5 ml, preferably measuring cup is used. But if for an amount 2.5 ml and less, measuring cups are not adequate. So you have to use oral syringes for that. So this is the point that from medication safety point of view, I wanted to make. And for oral iron preparations, avoid enteric coated and slow release preparations. Avoid giving, because iron has a lot of drug interactions. Avoid giving it with food. There are food iron interactions taking place. Calcium as a supplement also interacts, chelates with iron. So none of the components, iron or calcium, will be absorbed. Even the calcium content in the tea or food that we take can interact and can, many a times we prescribe this, and if we don't see a rise in hemoglobin level, then we say that the iron preparation that was supplied, particularly in the government sector, was of poor quality. But to my experience, most of the time it is because of the food drug interaction. You need to space this out. Calcium and calcium containing food should be either given 1 hour before or 2 hours after iron preparations. And with food, the iron will not be absorbed. It is preferably to give this iron after food, 2 hours after food. That is much better. Vitamin C, ascorbic acid, enhances the absorption of iron, so you can club it with that. Now, as far as choosing a salt preparation is concerned, ferrous sulfate, fumarate, they are all equal in efficacy and side effect profile. Only difference maybe in some of these is because of the cost. There is a systematic review done by, again, Indian Academy of Pediatrics. They found a slight evidence in favor of ferrous sulfate, but more or less they are of equal efficacy, and low dose is as efficacious and with fewer side effects. Now, one more point that I want to make here is, as we know, iron will turn the stools green or black in color, and many of us do not explain this to the mother, and mother gets frightened, after starting this iron preparation, something new has happened to the child, and they may not give the medicine to the child. So one should explain this properly to the mother, not to get alarmed. Sometimes they get over alarmed because of this. And also, in fact, I would rather take this as a sign of compliance. If you check on the color of the stool, and if the mother says it is green or black, that means the mother is giving this medicine to the child. And of course, adverse drug reactions, GI and iron overload, we need to be caring about. This is the systematic review done by IAP was concerned. There are guidelines on iron deficiency. I won't go in more details, but I thought medication safety point of view, I must highlight in this session. Dr. Puneet will be talking in details. And now, from this session, that the take home that we want is that a regular screening and assessment should be done. Our role as a general physician would be nutritional counseling, management of nutritional disorders, and prevent and intervene early if you find that there are signs of undernutrition or some deficiencies there. You may have to collaborate with other healthcare professional, dietitian, nutritionist, and other healthcare professionals, as the case may be, depending on the complications that the child may be having. And ultimately, prevention is better than cure. So we need to invest in health promotion and education of this. And I think all of these, I'm very happy to introduce the 7th edition of Standard Treatment Guidelines, which have been recently published. It is currently, stocks are not available. Maybe another week's time, stocks will be available. So all of these things that we have been doing right from 2002 onwards is included as part of these guidelines. You may, if you require, you may refer to these guidelines. I think I'll stop here and hand over these stage to Dr. A.P. Dubey. He's an expert in this, and he can elaborate more on very specific aspects of diagnosing and managing these nutritional deficiencies. So over to you, sir. Yes.
Hello,
Hello, sir. We can hear you.
can you see my slides also?
Yes, sir.
Slides are visible?
हाँ जी sir, दिख रहा है.
Okay. So, just a minute. Right. So, and thank you, Dr. Gita. I think you have elaborated a lot of points, especially so regarding the overnutrition part, as well as junk food, and some part regarding your micronutrient, including iron. I will cover mostly undernutrition rather than overnutrition, because that is a major challenge as far as treatment part is concerned. Obesity is also becoming a problem, but not so at the moment. So let me begin with that. Malnutrition means abnormal nutrition, which can be either undernutrition or it can be overnutrition or obesity. And there can be specific nutritional deficiency disorders, which may include various micronutrient deficiencies, as she has pointed out, including anemia, iron deficiency, iodine deficiency, and various other micronutrients which may be there. So this will be covered by Dr. Puneet later on, but I will be covering mainly under nutrition part and various kind of definitions and their management part. You can see an undernourished child. This is what we are discussing today, and you can see the obese children also here, and that is the another spectrum. You can see from undernutrition going to the overnutrition. So to classify, there are three phases of malnutrition. As far as the overall reporting is concerned, or when we compare globally, then we say what is stunting, what is wasting, and what is overweight. Now, the stunting means the child is too short for his particular age, right? It means that the children have, for their particular age, they are short. So height is basically affected, and this is more so a sign of or a feature of chronic undernutrition. Now, the wasting means too thin for their height. Means the children, although their height has not been affected, but their weight is mainly affected. And this is mostly what is being seen in acute malnutrition. And you can see the numbers here. The stunting is much, much more common, 149 million compared to wasting, which is 45 million or so. So children more suffer with chronic nutrition, but there are others who have severe acute malnutrition or acute malnutrition also. And we have to take care of these children much more than the stunting part. Overweight children, it's not very high at the moment, 39 million only under the 5 years of age, and this is a global estimate. This is what is being presented presently. Now, you can see that large number of deaths among children under 5 are because of malnutrition, almost to the tune of 69% or so. So malnutrition is the ultimate, basically, factor which plays a major role as far as they may be dying of pneumonia or diarrhea or some other intercurrent infection, but malnutrition is one common factor in these. Our country accounts for almost 1/3 of wasted children globally. I've already told you what wasting means, that they are too thin for their particular age. India ranks 102 among 117 countries as per the Global Hunger Index, and the children, 59% and 53% women are anemic. So iron deficiency anemia, which is the commonest part. These are NFHS 4 and NFHS 5, almost 5 years interval data. And you can see here that we have improved as far as the stunting, wasting is concerned, but we have increased as far as the overweight is concerned and anemia also. So this is something worry, that children with anemia have shown an increase in the two surveys, National Family Health Survey 4 and 5. So we have to take care of anemia Mukt Bharat, what we are presently, government of India is focusing on. That has to be taken care of. These are the 5 states with highest percentage of under 5 stunted children, their height is low. These are Jharkhand, UP, Madhya Pradesh, Chhattisgarh, and Rajasthan. And you can see as many as 32 to 42% children are underweight. Stunted. These are the stunted under 5 rural kids as far as the rural areas are concerned. And you can see here that the NFHS 5, although it has come down, but not significantly. These are the percentage of underweight children. Bihar has the highest number, and going on down, going up to the smaller states like Mizoram, Sikkim, and Manipur. You can see almost 40% or 41% children are underweight. This is the anemia, as I said, percentage increase in under 5 rural kids from NFHS 4. You can see as many as 65 to 70% children have in the rural area anemia. And this is the deaths attributed to undernutrition, almost 53%, or as I said, 69% somewhere it is said. And mainly it could be pneumonia, diarrhea, measles, and so on. But mainly the deaths are attributed to undernutrition. So that is the main focus, you can say, main factor. And then child may have associated problems as well. What are the contributors to that kind of high case fatality? No distinction between acute and rehabilitation phase because of reason that we don't realize. There is excessive use of IV fluids, diuretics, and albumin, which we will discuss. Not keeping the child warm and euglycemic. Low index of suspicion for infection, so we don't treat them adequately. Early use of diets which are higher in protein, sodium, and energy, especially sodium, and too early to start protein. Failure to monitor food intake, so we don't follow them up properly, and we start iron much earlier than what should be done. So I will be discussing these topics in detail later on. So please remember that these are the main contributors as far as the mortality is concerned in these cases. And the mortality rate is as many as 23.5% in severe malnutrition, or we can go that severe acute malnutrition, and it can be as high as 50% in edematous malnutrition. So how do we classify these malnutrition? So clinical, the classifications can be different. One, I showed you that there is stunting, wasting, and undernutrition, overnutrition. Another one is clinical. Clinically, you could classify them as marasmus, kwashiorkor, or marasmic kwashiorkor. Marasmic kwashiorkor is the one which is between the two, but marasmus and kwashiorkor, these are the two different forms of clinical forms of malnutrition. Now, the differences between these two are that in the kwashiorkor, although the child is underweight but has edema, and the other hair changes, moon phases, skin changes are already there. But in contrast to this marasmus, this child is very underweight and there are thin muscles, thin fat, no edema, and the child looks like an anxious look, old man's face, what we say. So here the child has got miserable expression in kwashiorkor, whereas in marasmus the child has got anxious look. So you can differentiate between the two. I'll show you the clinical pictures. This is the child with kwashiorkor. You can see edema all over, anxious look of the child, and there are few skin changes you can make out. This is the child with marasmus. See anxious look of the child. The ribs are very much visible. The child's very muscles are very thin, and this overall the child is severely underweight. So this is marasmus, and that is kwashiorkor, and in between there can be marasmic kwashiorkor. But this is what is the clinical form of presentation. Presently, we may not see any child with classical kwashiorkor, are very few cases, but marasmus we still see numbers. So let us concentrate on this acute kind of malnutrition. Chronic malnutrition, as I said, can lead to stunting, but acute malnutrition is more as far as the important as far as the management part is concerned. So it can be again further divided into moderate acute malnutrition, or what is presently known as MAM, and severe acute malnutrition, what is presently known as SAM. The difference between the two is that in MAM there is the weight for height is between -2 to -3 Z score, whereas in severe acute malnutrition it is less than -3 Z score. There are other features also which are diagnostic of severe acute malnutrition. It includes mid upper arm circumference less than 11.5 centimeter, bilateral pitting edema. Please remember, pitting edema bilateral of nutritional origin. It should not be like a child with nephrotic syndrome or any other condition. Marasmic kwashiorkor, both wasting and edema can be there. So various features which are there. These are the criteria. Any one or more of the following: weight for height or length less than 70% of the NCHS or WHO, and median or less than 3 Z score. So less than 3 Z score is, as far as the IAP is concerned, we are taking as far as the Indian children are also there. Visible severe wasting, as we saw in marasmus. Edema of both bipedal edema, both say feet, nutritional origin, and mid upper arm circumference less than 11.5 centimeters. So any of these, any one or more of the following, this will call as SAM or severe acute malnutrition, which is the main concern as far as the management part is concerned. You can check edema. You can see here on the on the foot, whole body you can see. Then you can take the mid upper arm circumference on the left arm. Normally we take, and if it is less than 11.5 centimeters, then the child is severely malnourished. This is edema. You can see both low feet, and this is how mid upper arm circumference is being taken on the left upper arm. So how do we assess the child who has got severe acute malnutrition? So diagnostic features, as I already told you, all these are there: weight for length less than 70% or less than 3 SD, edema both feet, weight for height or weight for length cannot be measured. Then you see the clinical signs, that is visible severe wasting. You can see on the chest, you can see on the arms. Child with visual severe wasting appears very thin and has no fat. There is severe wasting of the shoulders, arms, buttocks with visible ribs. So how do we go ahead? First thing is good history taking of recent intake of food and fluids, usual diet of the child before the current illness has started, because the parents may seek the attention, medical attention only when there is some current illness. Child has got fever or some other kind of infection. Breastfeeding Very important history of breastfeeding, duration and frequency of diarrhea and vomiting if the child has, type of diarrhea, watery or bloody, means dysentery can be rare, poor appetite, family circumstances, chronic cough, contact with tuberculosis. These children are much more prone to develop tuberculosis, and therefore it is important. Recent contact with measles. We are all aware that measles is a infection which can precipitate acute malnutrition. So therefore, very important. As far as the child is under 5 age, children are concerned, and known or suspected HIV infection. Then look for signs of dehydration. So you can see shock, cold hands, slow capillary refill, weak and rapid. Now please remember that putting edema on dorsum of foot after applying pressure for a few seconds. But sometimes this can be misleading also in case of malnourished child. Signs of dehydration may not be present. So we will come to a little later. Severe palmar pallor, so anemic child, and localizing signs of infection, including ear and throat infection, skin infection, or pneumonia. These you have to look for in this child, because the child who is malnourished may have signs of dehydration, shock, and anemia and infection. Now, this is how it can be identified in the community by this mid upper arm circumference, and which is less than 11.5 centimeters. Uncomplicated forms can be treated in the community with ready to use therapeutic food, or UTF. Now, this is 85 to 90%. So, almost you can say only 10 to 15% children of SAM will require hospitalization. Rest can be treated in the community itself. Community-based management with RUTF can have a major public health impact, certainly. So, examination includes fever, rectal temperature, or if it is possible, that is the best. So, you have to look for both hypothermia as well. So, high fever as well as high, because many of the children may be hypothermic. Mouth ulcers, skin changes of kwashiorkor may be present if the child presents in that way. Signs of vitamin A deficiency, triconjunctival beta spots, keratomalacia, and some children may be photophobic and will keep their eyes closed. So therefore, important to examine the eye very gently so as to prevent corneal rupture. So please be gentle as far as the eye examination is concerned. Then various investigations which may be required are especially blood glucose and serum electrolytes. More so if the child has dehydration, because you may miss sometimes these kind of problems of electrolytes, especially hyponatremia. Then hemoglobin, because the children may be anemic, total and differential count for infection, and peripheral smear, especially for malaria, where the malaria is very endemic in that particular area. So that is very important. And also for anemia, what for maybe these children may have either only iron deficiency, or usually they have iron deficiency and vitamin B12 deficiency both. So peripheral smear examination is also important. Peripheral smear for malaria, I already told you. Chest radiograph for infection and also for tuberculosis, because these children may have associated other infections as well. Blood culture, urine culture, if facilities are available, not necessarily in all cases. When to test, certainly after some time, not necessarily at the time of admission itself, because this time the child has got immunosuppressive, you can say, or he's not immunocompetent. So therefore, man to test may not be very positive at this stage. So you may do it later on. But yes, if you suspect tuberculosis, then get read. And gastric aspirate for acid fast bacilli if it is indicated. But the first four were chest radiograph, hemoglobin, TLC, DLC, electrolytes, and blood glucose. They are very important. So once we have done with the examination and the investigations, and now we have those already in our hand, how do we go ahead for management? Now this management is very streamlined. There is a phonograph. I am sure what's the treatment scenario? Without complication, without complication, after to manage as a man, you can take the dose. Well managed in the community. Now, severe acute malnourishment with complications. These children will, with complications, without complications, without complications can be managed as far as the outpatient care is concerned. So, not necessarily they should be admitted. But those with complications or SAM with complications, they would certainly need inpatient care and has to be hospitalized. So these are not more than 10 to 15%. Rest may be taken care by the outpatient care or in the community itself. So please remember that without and with complications, this is most important. Now the complications, what are the complications? Complications basically if the child has infection, child has diarrhea, child has severe anemia, the child has pneumonia. So all those things that SAM with complications. So any kind of associated problem, the child should be hospitalized. So WHO recommendations are there are 10 essential steps. Please remember 10 steps. These are divided into two phases. The first phase is initial stabilization phase, where the acute medical conditions are managed. So that is you stabilize the child first, and then a longer rehabilitation phase. Means once the child has been stabilized, then the child sometimes can be sent home also, and the rehabilitation phase may follow, which may continue for a longer period of time. Treatment procedures, please remember, they are similar for both marasmus and kwashiorkor. So clinical forms is different, but whatever the child may have marasmus or kwashiorkor or marasmic kwashiorkor, if the child fits into SAM, which we have said that one or the more criteria of weight and then mid upper arm circumference, edema, and severe wasting, these four, any of these, then the treatment procedures remains the same. Please remember this. So there is no difference as far as their management part is concerned. A small little bit difference in between, but not much. So the stabilization phase, you can see here that first week is the stabilization, day 1 to day 3 to 7, and the rehabilitation phase starts from week 2 and goes up to week 6. So management of the initial problems, most important ones are hypoglycemia, hypothermia, and dehydration. Initial one, they are very, very important to be managed at the time of admission itself, maybe in the emergency room. Electrolytes throughout the phase. So these are the initial phase, then electrolytes to be managed throughout this stabilization and rehabilitation phase. Infections are usually can be managed within within a week or two. Micronutrients, initially, please do not give any iron. Why? Because this iron may be utilized by the bacteria for their own growth if the child has got infection. So therefore, no iron initially, and iron can be given from second week, weeks 2 to 6 later on. So micronutrients, no iron initially, please remember this, not to be given. Feeding, cautious feeding throughout the period. Catch-up growth, you have to monitor after the child's stabilization phase has been over. Secondary stimulation is also very important later on, and then follow-up, prepare for the follow-up, so discharge and follow-up. So these are the 10 steps which we need to follow, and we will discuss just a little detail all of these. The first one is hypoglycemia. If the blood sugar level in the child is less than 54 milligram per deciliter, assume hypoglycemia if you are not able to determine the blood sugar level. In a conscious child, give 10% glucose, 50 ml bolus or sucrose solution orally. If the child is not accepting orally, give through nasogastric tube. And then you can start later on, starter diet. What is starter diet, we will see later on. In an unconscious or convulsing child, IV glucose can be given 5 ml per kg, 10% dextrose, which should be followed by 50 ml of 10% glucose or sucrose by NG tube. And later on, the starter diet or F75, what is known as, can be begun when the child regains the consciousness. Blood sugar should be monitored very carefully, and antibiotics should be started, ensured 2-hourly feeds also. So please remember, these are initially you have to give intravenous glucose. If not, then you can give through NG tube also. Blood sugar has to be monitored, and please remember that all these children will have some kind of infection, so you can start antibiotics, and then 2-hourly feeding has to be ensured. So this is about the hypoglycemia part. So assume hypoglycemia if you are not able to monitor or you are not able to estimate blood glucose level. Monitoring it can be done later on. Hypothermia. Please remember that most of the children who are hypoglycemic are also hypothermic. Most of the hypothermic children are hypoglycemic. So they both go hand in hand. So if the auxiliary temperature is less than 35.5 degrees Celsius or rectal temperature less than 35, then please see that the child is hypothermic. Start feeding right away. Rehydrate if required, not necessarily, but if necessary, yes. Rewarm the child. How? Clothe the child including head, cover with pre-warmed blanket, place near heater or lamp. Please do not use a hot water bottle directly because this can lead on to burns also. Place bed in the warm, draught free area. There is no direct air coming to there. Place on mother's bare chest, kangaroo mother care if necessary. Antibiotics, monitor body temperature. And for the prevention, monitor till it rises more than 36.5 and prevent hypothermia if the with frequent warm feeds. Keep the child covered, keep dry, avoid exposure, and place bed in warm, drought-free area. So please remember this. This is very important. MUSC consider under children 5. Yeah, that is all right. Under the age of 5 years, you are right. Up to the MUSC is up to the age of 5 years, and these same children are up to the age of 5 years. Majority of them, I would say almost 90% of them will be. Therefore, upper arm circumference to be taken between 6 months and 5 years. What we are talking is more than 6 months of age children and mostly up to the age of 5 years. So this is very important, the frequent warm feeds. Now, feeding is very important because if the child is hypoglycemic, the hypothermia may kill the child or may not respond very well. So therefore, please remember hypothermia and hypoglycemia both are very important in the initial stabilization phase. Third is dehydration. Now, please assessment of dehydration, basic format remains the same, but some signs like mental state of the child, because the child who is malnourished may be very irritable. Mouth, tongue and tears, they may be otherwise dry also, and skin turgor, here already the child has got so much undernutrition that the skin turgor is already lost. So even if the child is not dehydrated, you may not be able to make it properly, or if the child has got very much edema, still you may not be able to monitor it properly. So therefore, these signs are unreliable. But please remember that edema and hypovolemia, as I'm saying, edema can be there, both can coexist. So therefore, how do we assess the dehydration? So dehydration can be diagnosed with if there is a history of diarrhea with large volume of stools, the child has increased thirst, there is recent sunken eyes, because child with marasmus may have sunken eyes, but recently if the mother says no, previously it was not like this, then prolonged CFT or weak and absent radial pulse, decreased or absent urine flow, any of these. So urinary, so you have to ask for the urine, if the child is passing urine properly or not. So difficult to use clinical signs alone. So best to assume that all children with watery diarrhea have some dehydration, not severe dehydration. But please, if the child has that history, please remember that the child may have dehydration. Child may be in a state of septic shock also, and the signs and symptoms may be overlapping. So signs of severe dehydration in the absence of history of watery diarrhea, most likely due to septic shock. So if there is no watery diarrhea, please presume that it could be septic shock. Poor perfusion and oliguria may also be present in septic shock. Rapid steady pulse would point towards dehydration, whereas a bounding pulse would point towards septic shock. So please see the pulse of the child, and if it is rapid and steady, the chances of dehydration are higher. If it is bounding, then it is septic shock. Rapid improvement in IV fluid is a reliable indicator of dehydration. So if you give some amount of fluid and there is a rapid improvement, then certainly the child has got dehydration. Otherwise, the child may worsen. So if shock is not present, unless shock is present, treat with oral dehydration solution. 72 initial 70 to 100 ml per kg of ORS orally or through nasogastric tube over 12 hours. And later on, you can increase 5 ml per kg every 30 minutes, and then initiate feeding with rehydrating the child and give 2 hourly feeds using a F75 or starter formula. So no IV fluid as far as the possible if the child is able to take orally. Monitoring the progress of dehydration every 30 minutes for initial 2 hours and hourly for the next 6 hours. Avoid overhydration. Monitor stool and vomit frequency, urine frequency, respiratory rate, and pulse rate. So if the signs of overhydration, that is heart rate more than 25 per minute, increase, what we are talking about. If it is increasing more than 25 per minute, if the respiratory rate increases more than 5 per minute, there is liver size increasing, respiratory distress, short-term weight change, then certainly the child has got overhydration, and then you have to stop the fluid. Reassessment after 1 hour, initial reassessment, and whenever if you see that the child has got good dehydration, then you start oral feeds. To prevent dehydration when continuing watery diarrhea, you can start 5 to 10 ml per kg of ORS for every watery stool. If breastfed, encourage the child to continue breastfeeding and continue feeding with the starter formula, that is F75. So the fluid therapy use, if the child got severe dehydration, use intravenous or intraosseous route if intravenous is not possible. So please remember that we have to use ringer lactate with 5% dextrose or half normal saline with 5% dextrose. Do not use 5% dextrose alone. Please remember this, because there can be sometimes if you use this, osmotic diarrhea can be there. So then use either RL with 5% dextrose or half normal saline with 5% dextrose. Continue monitoring every 5 to 10 minutes. Assessment after 1 hour. If no improvement or worsening, consider septic shock is there, because with this the child should show improvement. If improvement, consider severe dehydration with shock and repeat ringer lactate 50 ml per kg, 15 ml per kg over 1 hour, and then you start reassessing again. So please remember that what I'm talking about is RL or normal saline with 5% dextrose. And stop IV as far as early as possible and start oral feeding, breastfeeding, or if necessary, NG feeding. Now we come to electrolytes. These children have depletion of potassium, magnesium, and normal or excess total body sodium, even though plasma sodium may be low. So please remember this sodium part has to be taken care of. So you may have to, if you are able to monitor it, that is the best. And electrolytes can be assessed, but if not, then probably the sodium part is that child may not have very low sodium. So deficiency usually take at least 2 weeks to correct. So there is no need for very urgently correction or very rapid correction. Hypokalemia, severe hypokalemia, serum potassium less than 2 millimole. With ECG changes, give IV potassium at the rate of 0.3 to 0.5 millimole per kg per hour. These are all standard guidelines. I think may not remember, but please remember this potassium to be given only if the child is passing urine. So once the child passes urine, then you start potassium. Give extra magnesium and potassium for at least 14 days. So 2 weeks time is very much required, both potassium and magnesium. Precautions: do not use a diuretic for edema. Please remember that child may go into dehydration. Giving high sodium increases mortality, so do not give high sodium. ORS is fine, but otherwise, once the child has dehydration has been treated, start with feeding F75 starter formula or breastfeeding. Treat symptomatic hyponatremia only if it is there. Serum sodium may be low. Do not add salt for the food initially. Treat the infection. These are common in severely malnourished children. So give routinely to all admissions broad spectrum antibiotics, because in severe acute malnutrition, the usual signs of infection such as fever are often absent. Means the child may be hypothermic even if the child has infection. So there can be no fever. Usually we can start with ampicillin gentamicin or oral amoxicillin. Avoid intramuscular injection because of less muscle mass, so give IV. And if not, then serum electrolyte is not always necessary. As I said, if you are not able to do it, potassium and magnesium, these are two most important. Sodium may not be given. If the child has diarrhea, only then sodium. ORS is required. Once the dehydration part has been corrected and the child diarrhea has stopped, you stop giving ORS and then start on oral feed. So if the child fails to improve within 48 hours, you can go on to cefotaxime or ceftriaxone. And if there is an specific infection, then add a specific antibiotics. Antimalarial treatment, if that film is positive for malaria parasite, and when the child starts improving, switch to oral medication wherever it is feasible. So IV or intramuscular injections should be avoided as far as possible. Switch to oral medications whenever is possible. So response to treatment: good response, alert and increased activity, improved appetite, weight gain, no danger sign like hypoglycemia, hypothermia, absence of clinical signs, and there is no evidence of systemic infection, no lab evidence. Poor response: the child still remains lethargic or withdrawn, appetite has not improved, poor appetite, danger signs are still present like hypoglycemia and hypothermia. So repeatedly child has got hypoglycemic episodes or hypothermic, remains hypothermic, and there is still clinical or lab evidence of infection. So when should we give? What is it? PCV in case of anemia with PCV means what? What do you want? You want to say vaccine, or I don't know what is PCV. Ensure that they have received appropriate and adequate antimicrobials. Ensure they have received proper micro and macronutrients. Reassess for site of infection. Reassess for resistant infection, malaria, tuberculosis. If they are not improving, screen for usual enteric pathogens and HIV in case of chronic diarrhea, and look for rumination, lack of stimulation, or other social problems. As I said, the stimulation which is required at the rehabilitation phase, very important. So micronutrient deficiencies, multivitamin supplement, folic acid, 1 milligram per day, zinc 2 milligram per kg per day, copper 0.2 milligram, vitamin A orally, vitamin K 1 milligram IV can be given, or intramuscular. Anemia, although anemia is common, iron should not be given initially, but wait till the child has got good appetite and starts gaining weight, usually week 2, as giving iron can make infections worse. So please remember this iron, precaution about the iron. Feeding part. Initial refeeding, start feeding as early as possible. The essential features are frequent small feeds. The child may not be able to consume all what you are giving, so start with small feeds. Low osmolarity, low lactose, oral or nasogastric. Sometimes you may give nasogastric, but orally. The energy should be 80 to see, multivitamins can be given per day also, orally also. As I said that these are the multivitamin supplements. You can remember, you may not remember, but usually double the dose what you give normally, right? So multivitamin 5 milligram on day 1, and then folic acid 1 milligram per day, zinc, copper, and then others, magnesium, and so on. Iron later on. So energy initially 75 kilocalories per kg per day. That is the starter, and later on you can go up to 100. Fluid should not be more than 100 ml per kg per day if the child has edema. If not, then 130 ml per kg per day can go, and continue breastfeeding in a young child up to the age of 2 years. These are the starter diets. This you will find in this monograph, Indian Academy of Pediatrics or WHO. What is a F75 starter diet, which can be either milk-based or it can be starter-based. 75 why we say, because this gives 75 kilocalories per 100 ml. So diet contains per 100 ml 75 kilocalories. So this can be made with either milk or various kinds of cereals as well. You can see a sugar, cereal flour, powdered puffed rice, vegetable oil, water, and this will give you 75 kilocalories, energy kilocalories. The protein to the tune of 0.9 or to 1, and lactose very low, 1.2 to 1 to 1.2 only. So low lactose, not very high protein, but energy F75. So initial diet start with frequently 10 to 15 ml per kg per feed, and volume should be 2 hourly, initially 130 ml, later on 3 hourly, 16 ml, you can increase it, then go to 22 ml. Calculations are based on the current weight. Please remember, it's not on the expected body weight, but what is the current weight of the child, and based on that, initial 1 to 2 days, 2 hourly, then go on to 3 hourly, and then 4 hourly, and these are the volumes. But the total volume, if you see, remains the same, 130 ml per kg per day. So you can increase the per kg feed volume, but then the frequency will come down. You can go up to 4 hourly. Facilitate catch-up growth. Once appetite returns, encourage higher intake, usually in 2 to 3 days. Gradually decrease the frequency of feed 6 weeks per day and increase the volume. Continue breastfeeding ad libitum. Catch-up growth, replace the starter F75 diet with F100. So that diet contains 100 kilocalories per 100 ml and 2.5 to 3 gram protein. So gradually decrease the frequency of feed, increase the volume at each feed, increase successive feed by 10 ml until some part is uneaten, remains there. Add complementary food, and usually you can go up to 200 ml per kg per day and 4 to 6 gram per kg per day of protein at a later stage. Continue to breastfeed. So always, if the child is young, continue to breastfeed. This is F100. Again, milk-based and cereal-based. You can see energy is 100. Protein is higher now, 2.9, and lactose is little higher, 3 to 3.8. These are all there in the monographs. Start complementary food provided they have comparable energy and protein concentrations. Once the catch-up diet are well tolerated, you can give khichdi, dalia, banana, curd rice, other culturally acceptable and locally available diet, which can also be offered. Monitor the progress. Good weight gain is more than 10 gram per kg per day. That is so, continue the same. If the weight gain is between 5 to 10 gram per kg per day, check the intake and infection part, manage it, moderate weight gain. If the weight gain is poor, less than 5 gram per kg per day, you should look for inadequate feeding, untreated infection, tuberculosis, and other social or psychological problems. So please remember that if the child is gaining 5 to 10 gram per kg per day, initially because of edema, there may be some loss of the weight, but later on, once the stabilization phase is over, then the child starts gaining weight, and then you can discharge only if the child has got good weight gain. The recovery is when we say is that when the child has got weight for height 90% of the NCHS of median, or you can say Indian Academy of Pediatrics standard also 90% of that child reaches, and there is no edema. So no edema and good weight, then you can say it is recovering. The child has got recovery. If the child fails to respond, then the causes could be how to judge it. Failure to regain appetite by day 4. Usually by day 4 they have good appetite. Failure to start losing edema by day 4. Presence of edema on day 10 is still there, and failure to gain at least 5 gram per kg per day by day 10. Not, then there is a primary failure. Secondary failure, the child initially has got good weight gain, but again failure to gain at least 5 gram per kg per day for 3 consecutive days during rehabilitation phase. Later on, initially the child was getting, but later on the weight faltering has been there. Discharge criteria are absence for infection, eating at least 120 to 130 kilocalories per kg per day and receiving adequate micronutrients. Consistent weight gain is there. No edema. He has completed immunization appropriate for that particular age. The child has not taken initially immunization. And caretaker is sensitized to take care at home. Points to remember is that last, use standardized treatment protocols, which are all available on the Indian Academy of Pediatrics site, and also on the WHO monograph is there. So you may not remember all those things in detail. So please always keep this chart with you and then use the standardized treatment protocol. Weight for height less than 70% of the NCHS median or Indian IP median. Bipedal edema, visible severe wasting. These children should be hospitalized if they have got complications. Restrict IV fluids to only septic shock or shock state. Otherwise, you can manage with oral fluids as well. Use low sodium ORS. Now, we have got 75 ORS. Isn't it? It's not 90 millimole now, no more. So that can be used very well in these children, because the previous ORS was has got high sodium, but this one has got low sodium. Promptly treat hypoglycemia, hypothermia, and infection initial phase during the stabilization phase only, and electrolytes, and then later on you go to the stabilization phase. So please remember, hypoglycemia, hypothermia, they go hand in hand. Therefore, they should be treated simultaneously. Low sodium ORS brands, all brands, most of the brands nowadays, all WHO ORS is available only with low sodium. There is no ORS which is available with 90 milliequivalent of sodium. It is only with 75. Points to remember: give 2 RDA micronutrients, delay iron. As I said twice, what is the recommended daily allowances of micronutrients? So give twice of that. Iron should be delayed. Give initially 80 kilocalories per kg per day and 1 to 1.5 per kg of protein in the initial week. That is F75 or F80, you can say. Rehabilitation phase, you can increase calories to 150 to 220 later on, and protein 4 to 5. So F75, F100, they usually correspond to these two. Weight gain of more than 10 gram per kg per day till recovery should be achieved before we say that the child has got good recovery. So good recovery is more than 10 gram per kg per day after the initial loss of edema. I think that is all as far as I have to cover severe acute malnutrition. If there are any specific questions, I would be happy to answer. Thank you very much.
Thank you, sir, for elaborating on management of malnutrition. I hope take home do's and don'ts are very clear now. What should be done? Sir, will you be staying with us, or should we take questions now?
No, I am staying with you, and most of the questions which you have asked in your pre and post test, I think Many of these have been covered in this lecture. I have already. You said that when to introduce complementary food and reduce F100. Basically, F100 is also a complementary food. But not necessarily that if the child has got older and you have home-based cultural food, you can give balanced diet. There is no issue as far as concerned. Once the recovery is good and child is sustaining, gaining weight, appetite is good, then you can start with your own food. So that will take something around 6 weeks, as I said, recovery phase total. So initially, first week and 2 to 6 weeks rehabilitation, and after 6 weeks, everything can be started as per your own culturally acceptable home-based or homemade preparations. Yeah, you can share these slides with these participants if required.
A video recording of the session will be uploaded on the YouTube channel of NHSRC. You can access that anytime and listen to the.
There is no use to start appetite stimulant. They don't work in these children because basically the low appetite is due to undernutrition rather than anything else. And one more question, something was written that, what was the next question was? Can somebody write it again or should I see the chat box?
There was, shall we use appetite
Weaning
stimulants?
food when to start. We said we don't say now is a weaning food. Weaning food has been now done away. There's nothing like weaning. Now it is complementary feeding. So as I said, complementary or supplementary feeding can be started as early as possible. Right? Once the child starts accepting orally, then you give orally only, and there is no need of giving IV fluids or extra fluid for that matter. Nothing like weaning food nowadays. There is nothing like weaning food. Head circumference is not a diagnosing criteria. No.
That is just for screening, if at all you
No,
can.
head circumference we don't take for screening also. Mid upper arm circumference.
Yeah, mid-arm.
There are other criteria also.
Corrected.
I'm not going to detail, but that is basically for research purpose. For community purpose, you do mid upper arm circumference. For all other cases, no, not even for screening head circumference. And for all other cases, it is the best thing is the weight. So weight for height, weight for age, height for age, weight for height. These are the three main criteria: weight for age, height for age, weight for height. Weight for age is affected in acute malnutrition, height for age is affected in chronic malnutrition, and weight for height will be affected in acute and chronic malnutrition. But now the terms have been changed, and what we say is SAM, that is severe acute malnutrition. Criteria I have already told you. What we say MAM, criteria I have already told you. And for management purpose, these are the classification.
What advice for SAM children without complications?
Without complications, they can be managed at home with the starter diet, which we have said F75 diet to start with. They have no complications. So gradually we see, means they will require more follow-up. Maybe you can call them after 3 days and see if their appetite shows good improvement. So that is one way to treat these children. Secondly, sometimes what we see is that we used to do appetite test also. Where these nutrition rehabilitation centers, they see this appetite test. What they want, they give basically one portion depending upon the weight of the child, khichdi or dalia they give, and see if the child is able to eat 3/4 of that. If the child is able to eat that much part, then probably the child can be managed at home. If not, less than that per feed, then probably the child will require admission. But these are criteria which are basically locally you can, start, you can do. If you are having a large number of children and you are not able to admit all of them. But basically, if your child has got complication, diarrhea, pneumonia, infection part, then the child with SAM will require hospitalization.
Since GI intolerance is there, what time after meals for iron?
You have already told you 2 to 3 hours.
Generally, immediately if you give iron with meals, it binds with the fiber, so absorption is not good. So after meals, 2 hours, maybe 1 hour 2 hours after meals, iron absorption is better. And also somebody asked about why slow release preparation is not given. Because slow release preparations stay in the gut for a longer time, and for this reason they have more side effect, especially the gastrointestinal side effect. They have more time for interaction with various foods, because they are staying in the gut for a longer time. And also the iron absorption is higher here, so there are chances of overload with sustained release preparations. So mainly because of the GI side effects and the food drug interactions, slow release preparations are not advisable.
This is somebody written many times, giving F100 also, child is not gaining weight. So I have already told you that either the child has got infection which has not been treated properly, or compliance is poor. So please see for chronic infection like tuberculosis. So that is much more important when the child is not gaining weight even after giving F100 for a certain period of time. And model for diet chart for STEM children managed in community has already to do F100 diet chart is already there. So you can start with F100 diet chart and later on can go increasing the amount, and then that will go up to, you can go up to 180 to 200 kilocalories per kg per day also. So that is there is nothing like model, because this will depend upon the area where you are working. And if it is South India, then naturally rice based preparations will be there. North India, maybe wheat based preparations. So it depends upon. Now, so depending upon the area, but you can see that there are cereal based diet charts which are available with the IAP monograph and WHO monograph, and you can go through those and then prepare it accordingly.
The assessment anthropometric measurement, I have corrected that. There was a typo error in the pre-test. The correct answer is arm circumference
Mid
only.
upper arm circumference. MUSE is mid upper arm circumference. Head circumference has no role as far as the diagnostic criteria for undernutrition is correct.
That
Dr.
has been
Sangeeta has already
corrected.
told
That
you.
was wrongly typo error was there.
Thank you. Thanks everybody.
I think you can hold on to your questions. Dr. Dubey is
Sure,
going to
sure.
stay with us.
Sure, I am there.
Meanwhile,
Let Dr.
yeah,
Puneet
thank
start
you
her this
for
presentation.
staying with us. We have Dr. Puneet
Let her
now
start
with us.
presentation.
He'll be
Good afternoon, Sangeeta ma'am and Dubey sir. It was a pleasure listening to your talks. Even I learned quite a bit, and it's actually made my task far easier. So still, it's a huge topic, and I'll just start right away.
yeah.
Yes,
For
ma'am.
introduction, Dr. Puneet Sahi, she is working as Associate Professor in Department of Pediatrics at Maulana Azad Medical College and Lok Nayak Hospital. Over to you, Puneet.
Yes, ma'am. Ma'am, my slides are visible.
Yes, it is visible. All okay. You can start.
All right. So good afternoon, everybody. I hope you're still into the presentation because it is an important topic that we're going to discuss after what ma'am and sir have primed with you with. So what exactly are micronutrients? A very brief slide on that. Basically, it means vitamins and minerals. And what these vitamins could be water-soluble vitamins, which include vitamin D and C, and fat-soluble vitamins, which include A, D, E, K. Along with that, there are minerals, which can be macrominerals, which are required usually in doses of more than 100 milligram per day, and trace minerals, which are usually required in doses less than 100 milligram per day. Ma'am, am I audible? Because a couple of students are saying you're not audible.
You are very much audible. Maybe they have a problem at their end.
All right, great, ma'am. Then I'll move ahead. So after this talk of severe acute malnutrition and malnutrition, which is a part of hunger, you've seen there's something called protein hunger, there's something called calorie hunger, but there's also something which is the hidden hunger and which is the micronutrient deficiency, which is often overlooked and missed, especially in the context of the remaining two, which take over the prime spot. But if you actually look, the prevalence of micronutrient deficiencies or hidden hunger is so much so that it affects it over 1 in 4 people. That is almost 25% of the population has micronutrient deficiency or hidden hunger. So what is the Indian scenario like? We had the CNNS-SC survey between 0 to 19 years of age in 2019 in India. And look at this, 14 to 31% of children and adolescents were deficient in vitamin B12, A and D. 19 to 37% of children and adolescents were deficient in folate. And the problem is not just this much. In different regions, sometimes it has been reported to as high as 65 and 70%, which is just humongous. So for this particular presentation, it will be difficult for me to focus on all the vitamins and all the minerals that are there. But because we have seen that these particular vitamins and minerals are important, our major focus in the subsequent presentation will be on iron, folate, B12, vitamin D. I will be putting on some focus on vitamin A, and then we'll have a quick overview of vitamin C and vitamin K deficiency. So let's start with a case, and I want you to be a little attentive and active, although it's a very simple one. A 15-month-old boy was brought with complaints of paleness of body for 1 month, poor appetite, irritability, and pica. Now, this child is third born to a 24-year-old thinly built mother. He's been on exclusive breastfeeding till 8 months of age, and then he was started on diluted cow's milk, 1:1 dilution, which was the predominant diet till now. On examination, there is pallor, but there is no jaundice, no hepatosplenomegaly, no lymphadenopathy. What is the diagnosis? Anybody quickly? Yes, it is anemia, but what anemia? The history is giving you enough clues. Anybody? Yes, so some of you have said anemia, and at least a few of you are replying iron deficiency anemia. So what are the pointers? What were the, in this case scenario itself, you're getting a lot of risk factors for iron deficiency. So the common age group of presentation of iron deficiency anemia is between 6 to 18 months of age. Why? Because this is the age when most kids are weaned off. This is the age when complementary feeding is required. So now we know that in this particular case, 1, he was exclusively breastfed till 8 months of age. Breastfeeding beyond 6 months will not cater to the nutritional requirements. Secondly, the mother herself is thinly built. She's 24-year-old, a very young mother, and this is her third kid. So probably the mother's iron stores are also depleted. So that is an add-on inside. Then on top of that, the child has been fed on predominant milk diet, which is again a risk factor for development of iron deficiency because there is no food diversification happening. And then it is cow's milk, which is going to inhibit the absorption of iron. And lastly, it is diluted. So now imagine how many risk factors are there. Then you have other clues in history which shows pica. So often pica, which is eating of non-nutritional things, is one of the manifestations of iron deficiency anemia. And examination again gives you clue because iron deficiency anemia typically is associated with pallor, but there is no associated jaundice, hepatosplenomegaly, or lymphadenopathy. So right or it is likely to be iron deficiency anemia. Let's go ahead. Nutritional anemia is the commonest form of anemia in India, and iron deficiency is present in more than 50% of the anemic children. So you realize how important this iron deficiency is in Indian children. And iron deficiency commonly occurs in later part of infancy in preschool children, that is 9 months to 3 years, particularly if they are not receiving a balanced diet. I'd add another line here itself about B12 and folate deficiency, which again is common between 9 to 12 months. So what cutoffs we'll be using for anemia are what WHO recommends. So as a thumb of rule, just remember anything less than 11 grams per deciliter in a child above 6 months of age is anemia. So don't overlook a value of 10.2, 10.3, 10.5. Just go ahead, examine the child. If you feel the child may have risk factors for iron deficiency and iron deficiency anemia. So prime yourself to look at hemoglobin values which are not normal, because we often pass off 8.5, 9, 9.5, 10 as normal. It is not normal. You should look for it. You should particularly look for iron deficiency, because the effects of iron deficiency are not just restricted to anemia. So do you realize what is the large scale impact of iron deficiency? It is not just anemia. It is also the cognition and neurobehavior of the child, all of which is likely to be reduced if this child has iron deficiency. And many a times it is an irreversible damage. So now what will be the large scale impact? Such kids, when they grow into adults, they are less likely to be productive adults with low wages and GDP daily losses. And therefore, there is going to be not just a health burden, but also an economic burden. So iron deficiency is not just anemia. There is so much more to it. So we should recognize and treat it. And what do you get in dietary history? I've already discussed delayed or inadequate weaning with predominantly milk-based diets, which results in poor iron intake. And predisposing factors are introduction of cow's milk before the age of 1 year, excessive milk intake. So there is excessive reliance on milk and milk products in the Indian household, especially in North Indian populations, and that is predisposing our kids to iron deficiency, because that restricts food diversification, and also cow's milk prevents absorption of iron. And then of course there is poor intake of iron-rich foods and use of low iron formula. Megaloblastic anemia, which is due to B12 and folic acid deficiency, may be due to use of goat milk. So goat milk is folic acid deficient, and this can also predispose to folic acid deficiency anemia. And vegetarian diet, because B12 is primarily found either in non-vegetarian food, or it is formed by microbes which might be present on the surface of fruits. So if a person is predominantly in vegetarian diet, then again, they are predisposed to develop this B12 and folate deficiency anemia. Now, what would you find on physical examination? So the most characteristic finding is pallor, which is detected on the palms, nail beds, and oral mucosa. So look at the hand. Now, the important thing is when you look for palmar pallor, yes, you're right. Actually, you suppose someone has commented 200 to 400 ml per day. Yes. IAP latest recommendation says that you should restrict milk intake to less than 600 ml per day beyond 6 months of age. But when we are counseling, we do say around 400 to 600 ml per day. Now, if you look at palmar pallor, what is important to note is that you just don't look at the palm of the child. You have to compare it with the examiner's palm, provided the examiner himself or herself is not anemic. Now look at this particular child's hand. It is as pink as the examiner's hand. But if you look at this kid, his hand has gone pale. So this particular kid has pallor. Again, an Indian kid being compared to an Indian examiner, and look at the difference in the degree of palmar erythema. So the palm of the child is compared at the same level and parallel to the ground, and this is most characteristic feature of anemia, which can happen in iron deficiency. You can also look for conjunctival pallor. So look at this. Then you have oral mucosal pallor, and then you can have nail bed pallor. So these are the normal pink nails, and this particular kid has nail bed pallor. When you have iron deficiency anemia, although it is very rare, you can have examination findings in ID will normally be unremarkable with no lymphadenopathy or hepatosplenomegaly. Some children may develop platinikia, which is flat nails, or koilonychia, which is spoon-shaped nails. But honestly, I haven't yet seen a single kid with these findings. You'd be lucky if you would have. Physical examination, other clues. For example, the child may have associated angular stomatitis and cheilitis. The child may have atrophic dascitis. And these are features which may be suggestive of iron and vitamin B12 deficiency, particularly angular stomatitis and cheilitis. This could be feature of a B12 deficiency. So how would you go ahead with the laboratory diagnosis? The first go-to, even for iron deficiency, is a CBC with RBC indices with peripheral smear. And it is important to use age-adjusted norms. So we come back to the case. The history stays the same. Now look at the complete blood picture. We have an HB of 8.1, which is of course low because we said any value less than 11 is anemia beyond 6 months of age. Now you look at the MCV, MCH and MCHC. All three are reduced. And the RDW is increased, red cell distribution width is increased. So when you have anemia, which is microcytic, hypochromic, with an increased RDW, it is highly likely to be iron deficiency, especially when you look at in the context of the history and examination of the child. So this gives you an idea that this is iron deficiency. I have taken this chart of normal values from the latest IAP guidelines, which were published in 21 on nutritional anemia in children, which focuses on so someone has asked HSM and LAD. HSM is hepatosplenomegaly, LAD is lymphadenopathy. So that is usually not present in iron deficiency. Now this is the chart which gives you normative values for serum iron studies, which help you identify iron deficiency and iron deficiency anemia. So serum ferritin is the first and the foremost test that you do after a CBC evaluation with a peripheral smear to check for iron deficiency anemia. It is not serum iron levels, it is serum ferritin, which is the single most important test after a CBC evaluation to confirm the diagnosis of iron deficiency anemia. So serum ferritin is basically the storage form of iron, and it is the earliest marker to go down when a child becomes iron deficient. So in a child less than 5 years, a serum ferritin of less than 12 micrograms per liter. And in a child more than 5 years, a serum ferritin value of less than 15 micrograms per liter is suggestive of IDA. If for some reason you do not have the ferritin values, then the next most important reliable investigation is serum transferrin saturation, for which IAP has recommended a value of less than 16% as suggestive of IDA. But all these values have to be read in the context of your clinical history, examination, and the CBC and peripheral smear findings. So we had the peripheral smear of this kid. Now look at the RBC sizes. These are all micro size. These are smaller sized RBCs. Okay. Now look at the central pallor. The central pallor is more than 2/3. Normally, RBCs should have less than 1/3 of central pallor, but here the central pallor is increased and the rim of hemoglobin is reduced. So this is hypochromic. And look at the different shapes and sizes of RBCs. So anisocytosis means they are different sizes of RBCs. Some are larger, some are smaller. And poikilocytosis means they have different shapes. One is teardropped, another is teardropped, one is spherical, one is oval. So this peripheral smear is suggestive of iron deficiency anemia. We got the iron profile, the ferritin was low, transferrin saturation was 12%, PIBC was increased and serum iron was low, so a confirmation of iron deficiency was done. So now how do you treat it? Ma'am, Sangeeta ma'am has discussed very well regarding the nitty-gritties of what we should be looking for while treating anemia. I'll quickly recap them and emphasize a few additional points. So the normal, long back we were saying that the treatment doses of iron are 4 to 6 mg per kg and the prophylactic doses are 2 to 3 mg per kg. But the latest IAP recommendations say that oral iron dose of 2 to 3 mg per kg per day and dose of that is elemental iron. We are again emphasizing when you look at the preparations, they say 5 ml 100 mg. Sometimes that is the total amount of iron that is present, but you have to know the amount of elemental iron that is present. For example, ferrous sulfate, which is the commonest form of iron preparation, which is used in our government setup, has 20% elemental iron. So if it is a preparation of 100 mg, it will have only 20 mg of elemental iron. So this dose is calculated as per the elemental iron, right? So you should be careful about the dosing. And it is recommended to be given in a single daily dose. So initially we were giving in 2 divided doses, 3 divided doses, but now it is said that a single daily dose will result in and equally good absorption, and it will improve the compliance. So 2 to 3 mg per kg per day of elemental iron in a single daily dose. Divided doses can be given in cases of gastrointestinal adverse effects. So if the child is coming and as you can see, almost 10 to 20% of the patients may develop GI side effects like nausea, vomiting, diarrhea, and sometimes constipation, and it may actually make them non-compliant to therapy. So apart from counseling them that these side effects are expected, in these particular situations, you can actually give them divided doses instead of single doses. Yes, it is recommended that iron ideally be taken empty stomach. So you say either 1 hour before meals or 2 hours after meals. That is when their absorption will be best. If you give it with meals, the absorption is likely to be hampered. Also, as per the latest IAP guidelines, folic acid is to be given along with iron, and in fact, whatever preparations are available in the market, a combination of iron and folic acid. So by default, you would be giving folic acid with iron. And how long should this iron therapy be continued? It should be continued for at least 8 to 12 weeks after normal hemoglobin level is achieved. So it may take approximately 2 to 3 months for the child's hemoglobin to normalize. And then after normalization of hemoglobin, you should continue the therapy for another 2 to 3 months to replenish the iron stores. I'll talk about folic acid doses, all right? Now, ferrous sulfate. Now, what about the preparations? So, oh my God, so many questions back to back. So, we also have different preparations of iron, but remember, there are 3 important preparations which, as per IAP, are equally efficacious. These include ferrous sulfate, ferrous gluconate, and ferrous fumarate. So, these are the 3 preparations which are the most equally efficacious. However, because of economical availability, ferrous sulfate is the most commonly prescribed form. Now, ferrous, as someone is asking, vitamin C, whether it is to be given with this thing iron. So, IAP recommends that routine supplementation with vitamin C is not recommended for treatment of IDA. However, they say that if the child or the person eats a citrus fruit during the same period, then the absorption of iron is improved. But there is no recommendation to actually give vitamin C along with iron. And another preparation of iron, that is ferrous ascorbate, which has vitamin C in the preparation itself, has been also seen. It is also very effective, but it is very costly as compared to sulfate, gluconate, and fumarate. Therefore, it is not the first choice, especially in the government setup that we have. So the recommendation still says ferrous sulfate. Okay. Now, I've already discussed this. Also, you will have some preparations which have ferric salts. So ferric salts are not to be given. Ferrous salts are the one to be given because ferrous has much better absorption as compared to ferric. Also, ma'am has already discussed use of prolonged release or enteric-coated iron tablets or liposomal or iron formulation. So there have been a couple of MRs and companies will be coming to you and selling these liposomal iron formulations, but it is not recommended because they say that absorption of iron from these preparation is actually less as compared to the other preparations, because majority of your iron absorption is going to happen in the duodenum and upper part of jejunum, and these enteric coated tablets already bypass that area by the time they open up. So the absorption is not good, and there are a couple of other reasons which Sangeeta ma'am has already elucidated. So these are not recommended for use. Then when do you follow up? Suppose you have started treating a child with iron deficiency anemia. When should you follow up? So if the child had severe anemia, which is also definition given by WHO based on the amount of hemoglobin. So anything less than 7 becomes severe anemia. So if the child had severe anemia, you should follow up for first follow-up visit on day 7 to see if the child has started improving or not. However, if it is mild and moderate anemia, you can call up for the first follow-up on day 14. And if the child has any additional problem, of course, you're going to call up earlier. So how are you going to evaluate response to treatment? You should not use, someone has asked when we should use entry-coated tablets. You should not use entry-coated tablets. They are not recommended. So evaluate response to treatment. Now, iron clinical response will be the first to happen. So the clinical features of irritability, appetite improvement, these all will improve within 24 hours of starting iron. Retic count is the next thing that you see starts improving within 72 to 96 hours of iron treatment, and hemoglobin rise occurs 1 gram per deciliter in 7 to 14 days. So if it is severe anemia, you will see a rise within a week. If it has been moderate to mild anemia, you may see a rise in 14 days. Now, it may so happen that you have started treatment for iron deficiency, but you see non-response. What do you mean by non-response? That even at 14 days, you followed up this child and there is no rise in hemoglobin whatsoever, or the clinical manifestations have not improved. So you feel that, okay, something is not working. So what should you do? First thing, you should evaluate the compliance to treatment. Has the child been taking the correct dose in the correct manner, that is 1 hour before meals or 2 hours after meals? Has the child been taking the correct preparation? So sometimes even within our hospital, we are getting sometimes we are getting preparations which are 5 ml, 30 mg of iron. And then we are also getting preparations which is 1 ml, 20 mg of iron. Now, if you fail to actually tell the cross-check which preparation of iron this particular kid has received, he may be underdosed or overdosed in both situations. So you really have to go back, check the dose and check the preparation, check the amount. So you have to actually cross check, because sometimes they don't understand what is 5 ml. So you have to check the cap of the bottle and show them the mark where there is there, and then you tell the mother, okay, this is the amount that you're supposed to take every single day. Now, once you've done that and you feel that, okay, adequate compliance was there, dose and preparation was all fine, yet the child is not responding, now is the time you should think, okay, there might be an additional factor which is contributing to this anemia, which I have left unidentified. So look for features of infections like UTI, which might be masked, or some chronic disease the child might be having, or the child may actually be suffering from an underlying celiac disease, Proud's milk protein allergy, or an anemia of chronic disease. So we'll not delve into depth of all of this, but remember, if you've checked all of the initial parameters and still the child is not responding despite adequate doses of iron, you should think of alternate causes and now start evaluating the child for these other causes. And now also, treatment is not just about giving them the supplemental iron for those 2 to 3 months, because if you fail to do this part of it, that is telling them about the diet, health and nutrition education, what will happen? Once you stop that iron, the iron deficiency anemia is going to come back. And what you've done is a very short-term management, but the long-term management is always going to be dietary diversification, although it is a tough thing to do in our setup, especially with the kind of population that we get. So tell them to take a lot of iron and folate-rich dark green leafy vegetables. See, dark green leafy vegetables are one of the best sources of so many vitamins and minerals. We should include them in hordes in our diets. Intakes of vegetables and foods that promote iron absorption. So all citrus fruits and vegetables like carrot and lemon and berries, which can be included in your diet, should be included. Also, optimal feeding practices, like they should be told that beyond 6 months of age, you have to start weaning. We are getting kids at 9 months, 10 months who are still on exclusive breastfeeding. It's surprising. So somewhere our counseling is not so up to the mark. So we have to counsel them about adequacy of weaning, about how to wean, what foods they can add when they have to wean, and also emphasize that milk intake has now to go down only up to 400 to 500 ml per day, because if you keep feeding the child with milk and milk made stuff, then he'll never be hungry enough to try other stuff, so you have to diversify the food. Also, you have to emphasize that they have to avoid taking foods with iron-rich foods with foods that inhibit absorption. So it is a very common Indian practice. We have our breakfast, and then with our breakfast, we are having tea. So tea has tannins. Now those tannins are going to, whatever iron you're taking in your food, it is not going to be absorbed. So that is why these are little things which go a long way, and you have to counsel the family regarding this, right? Also, an important part is deworming. So a lot of our kids are again coming from that strata where, and these kids are also the age group when they will be exploring so much and therefore are predisposed to worm infestations. So deworming is to be given because these worms, when they're present in the intestine, they're not only going to, they're going to absorb all nutrients within the intestine and ultimately unmask anemia, iron deficiency in these kids. So we say that albendazole deworming is recommended to all children beyond 1 year of age, and 6-monthly deworming actually has been recommended even up to 18 years of age as per the latest guidelines. So the doses are simple. If a child is 6 months to 2 years, the dose is 200 mg, and if the child is more than 2 years, the dose is 400 mg, and you have both syrup and tablet formulations available. So prevention. Now, prevention is obviously always going to be better than cure, and the government forever has realized that iron deficiency has been one, difficult task for us to take care of, and therefore several programs have come over years. But of all those recommendations, I'll tell you what we are doing right now. Iron supplementation at the dose. So this is prevention. This is not like these kids are iron deficient. This is those kids which are yet not iron deficient, and what we do as a part of program or as a part of our recommendations to prevent iron deficiency in kids. So iron supplementation in dose of 2 mg per kg per day of elemental iron in preterm or low birth weight infants starting from 2 weeks and continue till 1 year of age. This is NNF guidelines from India. So this is being done. Also the IAP guidelines which have been released in 2021 recommend this. All children should be screened for anemia. Now this is something new. All children should be screened for anemia at 9 to 12 months, at 5 years, and in adolescence. So this is also the latest recommendation. So when they're coming for your measles, measles containing vaccine at 9 months, you should be screening them for anemia. Also, we have the latest Anemia Mukt Bharat program. There are multiple programs that have been there in continuation. The latest one, a slight modification of the previous one, launched in 2018, Anemia Mukt Bharat program, recommends intermittent iron folic acid supplementation for all children more than 6 months of age. And delayed cord clamping is there. No, for full-term neonates, iron supplements are not recommended. But intermittent iron folic acid supplementation starts at more than 6 months of age as per Anemia Mukt Bharat program. All right. So this is for preterm or low birth weight infants starting from 2 weeks till 1 year, because their iron accretion during the in utero period is inadequate because most of it occurs in the 3rd trimester. So they have inadequate iron stores, and as soon as they are born, the iron deficiency unmasks at around 4 to 6 months of age. That is why prophylactic iron supplementation is recommended at preterms or low birth weights. But for children more than 6 months, intermittent iron folic acid supplementation is recommended. So this is the Anemia Mukt Bharat. This is the Anemia Mukt Bharat guidelines, and you can see that not just children. So they've started from 6 months and they've continued till 19 years for children, and almost bi-weekly to weekly supplementation of iron folic acid is ongoing. Okay, so they have liquid dispensers for the younger ones and they have tablets for the older ones. So jo hum bolte the na neeli goli and gulabi goli, all of this is a part of your Anemia Mukt Bharat, and they get it from their schools. All right, so once you've treated a child for iron deficiency, go back, emphasize that once your treatment for iron deficiency has been done, you have to go back and continue this iron prophylactic IFA tablet intake. Okay, so this is to be given to these kids. Now, next, move on to the next deficiency. So let's look at this case. A 9-month-old girl was brought with complaints of paleness of body for 1 month. And in dietary history, again, there is inadequate delayed weaning and diluted goat's milk intake. There is no significant family history. There is mild developmental delay. Height for ages at -2 standard deviation. Weight for ages -2 to -3 standard deviation. The examination shows pallor, knuckle hyperpigmentation, with no jaundice, no hepatosplenomegaly, no lymphadenopathy. And on a complete blood count, you have anemia. In fact, you also have low TLC and low platelets. MCV is increased, so it is a macrocytic anemia. MCHC is decreased, so there is hypochromia, and RDW is increased. Now, can you please give me a diagnosis? Lots of clues in this case are there. Yes, someone has said vitamin B12 deficiency anemia, excellent. But do you think it could be something else? What about diluted goat's milk intake? What is goat's milk deficient in? Yeah, it is deficient in folic acid. Yes, good, great. So it is probably it is a megaloblastic anemia, which is probably because of both B12 and folate deficiency. So a 9-month-old, again, the risk factors for B12 and folic acid deficiency. 9-month-old, inadequate delayed weaning, again a risk factor. Diluted goat's milk because deficient in folic acid, a risk factor. Developmental delay. Mild developmental delay is often a feature of vitamin B12 deficiency. Knuckle hyperpigmentation is a feature of vitamin B12 deficiency. And absence of significant hepatosplenomegaly and lymphadenopathy again points towards nutritional cause. So this history is pointing towards megaloblastic anemia, and then of course your complete blood count again gives you a macrocytic hypochromic anemia with all cell lines decreased. This happens in B12 deficiency. So suggestive of a B12 folate deficiency anemia. So B12 deficiency is commoner than folic acid. B12 deficiency is more common in infants born to B12 deficient mothers. Occurs during periods of 9 to 12 months because of improper weaning. Why would B12 deficiency? So our latest surveys also showed that adolescents are actually the group who have significant B12 deficiency. Almost 20 to 30% are deficient in B12. Probably because this is also the time of their growth spurts and requirements of all micronutrients increase during this period. And in Indian population per se, because a large proportion is vegetarian, therefore that itself is a risk factor for vitamin B12 deficiency. Now, what could be the clinical features? Neurological features could be there. Anemia, of course, is a feature of B12 folate deficiency. Then you have neurological features which include developmental delay, tremors, and infantile tremor syndrome can happen, which a less experienced resident might actually miss for abnormal movements or seizures, but you have to be careful and look at the history carefully to identify it as a tremor and also as an infantile tremor syndrome in the context of history and examination that you have. See, look at this particular kid's hands. There is knuckle hyperpigmentation. So look at those knuckles. They're dark. This is because B12 is also involved in tyrosine pathway, and because of B12 deficiency, somehow the pathway is modified in such a way that there is excess production of melanin. So there is hyperpigmentation in the body. Now, if there is severe B12 deficiency, it may cause pancytopenia. That means hemoglobin, TLC, platelets all go down. And when platelets go down significantly, you may have bleeding manifestations in the form of petechiae. So the second picture, this depicts a petechial rash, which may happen in severe B12 deficiency. And then you, of course, have the dermatological manifestations in which I've shown you the knuckle hyperpigmentation. You also have the angular stomatitis. And it is these dermatological manifestations which aid in early diagnosis, because neurological and hematological manifestations are the later manifestations which will occur when B12 deficiency has occurred for a long period. We ran a peripheral smear for this kiddo, And look at this, what we have. One, the size of the RBCs is larger. A lot of them are oval shaped. Look at this. These are oval shaped RBCs. And you have a neutrophil, which is hypersegmented. So normally the nucleus of a neutrophil should not have more than 5 lobes. But look at this. This is 1, 2, 3, 4, 5, 6, almost 7 lobes. So this is a hypersegmented neutrophils, and which is very characteristic of B12 or folate deficiency anemia. So, and leukocyte counts might be reduced. So we have a CBC which is suggestive. We have a peripheral smear which is suggestive. How do we confirm the diagnosis? We send in the B12 and folate levels. And I showed you a chart before in that B12 levels of less than 200 and folate levels of less than 4 are considered to be diagnostic of the respective deficiencies. And thereafter, we treated this kid as a megaloblastic anemia. So what treatment are you supposed to get? If there is mild to moderate anemia, you can go away with oral B12 therapy. So a lot of us, previously we were just into intravenous or intramuscular or deep subcutaneous, that is parenteral B12 therapy. But over the past few years, we have moved on to daily oral vitamin B12 therapy. So for mild to moderate anemia, you're going to give oral vitamin B12. The dose is 500 microgram in infants and 1000 microgram in older children, which is to be given for at least 3 months. And then you have to give another 2 to 3 months of therapy after normalization of hemoglobin, just like what you did in iron deficiency. Hey guys, are you there with me? I've not put you to sleep, right? All of you interested, still up? A long session we're having. Oh man, no responses. All right, at least a 1 thumbs up. All right, great. So wake up, wake up, wake up, wake up. Yes, a little more to go. So yes, okay. So you have daily oral iron therapy, oral vitamin B12 therapy. All right. And then you have, if because of B12 deficiency, you have severe anemia, or the child has developed any neurological manifestations like ITS, that is infantile tremor syndrome, or the child has developed delayed development, or the child has developed pancytopenia and bleeding manifestations. Now, these are serious manifestations of B12 deficiency. In these situations, we are supposed to go for parenteral therapy. And also in parenteral therapy, ideally, IM and deep subcutaneous is what is preferred, because the absorption from IM and deep subcutaneous is actually better than IV preparations. However, the catch is, if the child is having severe thrombocytopenia, then you'll have to go ahead with IV therapy only, because IM or deep subcutaneous could lead to hematomas. Okay. So I'll not read through so much this. You can, go back and read from the IAP guidelines, the dosings, but I've given you the highlights of when to give oral and when to give parenteral B12 therapy. So children with vitamin B12 deficiencies, when they are without neurological features, the treatment is given for at least 3 months, plus 2 to 3 months after HB normalization. So you would say anywhere between 5 to 6 months. But if a child has neurological features like infantile tremor syndrome or developmental delay, then we give therapy at least for 6 months. And we may extend it for another 2 to 3 months after HB normalization. So HB may normalize within this span of 6 months only. So you may need to give only 6 months of therapy, but you will need to give 2 to 3 months for replenishment of body stores. Now, someone was previously asking me the dose of folic acid. So folic acid deficiency is treated with oral folic acid, 1 to 5 milligram per day for 3 to 4 months. All right. So this is folic acid deficiency. If you're giving per se with this thing, iron per se, then there are already fixed combinations which are available in the tablets itself. So that is the dose. You don't need to supplement apart from that tablet. All right. So like, for example, in anemia Bharat, you already have IFE tablets. So you don't need to supplement folic acid over and above that. So, but if there is deficiency, you need to give oral folic acid 1 to 5 milligram per day for 3 to 4 months. Now, if you have concomitant B12 and folate deficiency, first you should start B12 in the initial 10 to 14 days and then follow it with folic acid. You should remember B followed by F, not the other way around. Because if you start folic acid first, it may actually worsen the neurological features of B12 deficiency. So that is because of the pathways in which B12 and folic acid are involved. And if you give it in the reverse order, folic acid followed by B12, there might be accumulation of homocysteine and other products which are going to worsen the neurological manifestations of B12. So always remember, if there is B12 and folate deficiency both, B12 should be started in the initial 10 to 14 days and then they should be followed by folic acid. Okay, B followed by F, just in alphabetical order. Also, folic acid should not be instituted alone if B12 deficiency has not been excluded. So if you've identified someone with folic acid deficiency, check for B12 deficiency also. All right. So if there is no B12 deficiency, you're okay with going ahead with only folic acid supplementation. But if there is B12 deficiency associated, then again, you first give B12 and then follow it up with folic acid. Also, dietary modifications I emphasized a couple of times. Reduce milk intake to less than 600 ml per day. This is as per the IAP guidelines. Also, increase the intake of non-vegetarian food if possible, and food diversification should be done. Now, often a question is, when do we transfuse blood? So, we often see in the casualty or in the OPD, kids are coming and they have a hemoglobin of 6 and a new resident is there in the OPD and then he gets very scared. Ma'am, it's 6 ka hemoglobin hai, transfuse kar dete hain. But that is not the only criteria to transfuse a child. So what do the guidelines say? Children with hematocrit of less than 12% or HB of less than 4, yes, even if there are no associated features of heart failure or any oxygen requirement, go ahead and transfuse. So this is an absolute indication if the HB is less than 4. However, if the child's HB is between 4 to 6, and there are no additional symptoms, you can wait and watch. You're anyways going to call this child after 1 week of institution of therapy. But if this child who has a hemoglobin of 4 to 6 has any of the following, like dehydration, shock, impaired consciousness, heart failure, or labored breathing, in that situation, you are supposed to admit and transfuse the child. And also what is important is that please, before you transfuse the child, take all pre-transfusion samples, because the moment you transfuse this child, and now after 1 day you remember, oh, I have to check for cause of anemia. Now, but you've already transfused, and now you will not know whether the underlying cause of anemia was because of iron deficiency, B12 deficiency, folic acid deficiency, or some other reason. For example, even if you're thinking of thalassemia, you'll not know, and you will have to wait for quite some time. So now your entire premise of what would be the cause of this anemia is lost. So remember, and even a single blood transfusion, and even in fact a single oral dosing of B12 folic acid is going to change the blood levels. So not just blood transfusion, you should send these levels, if you're intending to send these levels, B12 folic acid levels or serum iron profile, it should be done before you start the supplementation of these particular things, specifically B12 and folic acid, because they're very, very sensitive to oral supplementation. Having said that, if a child is a classical case of iron deficiency anemia clinically, and your CBC has shown microcytic hypochromic anemia with increased RDW, you actually don't even need to go ahead and do a serum iron profile or ferritin in such cases. You start iron if the child has clinical response. That itself is confirmatory of the child having IDA. This again, I'm telling you from the IAP guidelines which have been published. So we are done with iron, we are done with B12, and we are done with folate. And now we are moving to another important vitamin, that is vitamin D. So just to wake you up, these are all vitamin D deficiency features. Can someone tell me what is depicted in picture 1? Quickly. Anybody? What is depicted in picture 1? All right, frontal bossing. Yes. If I would have actually shown you the lateral aspect, you have seen that not just the frontal bossing, even the child has parietal bossing. And this is caput quadratum. When all four parts of your skull are increase in size and it appears like a box shaped head. This is caput quadratum. Now the second picture quickly, what is this? What do you see? The second picture guys, quickly, girls and boys. Yes, rachitic rosary. Good, great. The third picture, very, very evident. What is this? Third picture. I'm putting my arrow over here. This is, what is this? The third picture. I've just put my arrow over here. Wrist widening. Yes, so wrist widening. What about this kid? What is this in his legs? Genu valgum. What is this? Fourth picture. Fourth picture. Red arrow, big red arrow. Yes, great. Great, Jagriti. Okay, this particular picture. This is pectus excavatum, pectus carinatum. So all of these are features of rickets. All of these are problems of the growing bone. So when vitamin D deficiency affects the growing bone, that therefore rickets will happen only in children, because rickets is a problem of the growing bones. When it is happening in growing bones, it is known as rickets, right? When it is happening in an adult, vitamin D deficiency is going to lead to osteomalacia. But these are all features of the growing bones of vitamin D deficiency rickets. Now, anybody, what is this on the right side? What does this picture depict? What is this hand posture? Anybody? Yes, technique spasm. So the typical technique spasm of hypocalcemia, which will happen due to, yes, carpopedal spasm. Very good. Someone has actually mentioned the technical term. So symptoms of vitamin D deficiency in children. Number one, nutritional rickets, which I've shown to you in the previous slide. Other features could be hypocalcemia. So you remember, when a child is manifesting features in the growing bone, it is known as nutritional rickets. Remember this term. Other features of vitamin D deficiency could be hypocalcemic seizures, tetany or carpopedal spasm, as you can see in this particular child, hypocalcemic dilated cardiomyopathy, bony deformities, and osteomalacia. So this is the X-ray. Can someone tell me number 1, 2, 3, 4 features of vitamin D deficiency quickly? Quickly. What is this? Cupping. So look at this metaphyseal end. It has just cupped. It is not a straight line. It has cupped. This is cupping. Now what has happened at the edges? The bone is frayed. This is fraying. Then what has happened at the metaphyseal sides? There is playing. It is spread. The bone ends up spread. This is playing. And you can see generalized osteopenia of the bones. So these are all features of vitamin D deficiency. So no, who's saying hypervitaminosis? These are all features of vitamin D deficiency. These are all features of vitamin D deficiency or rickets. Now, how do guidelines, and again, I'm talking so much about guidelines so that, we have a good reference, but latest vitamin D guidelines recommend that serum hydroxy vitamin D cutoffs, if it is less than 12 nanogram per ml, it is deficiency. If it is between 12 to 20 nanogram per ml, it is insufficiency. So why do we need to know these terms? That is for treatment purposes. I'll subsequently tell you which are the kids who need treatment. So first, we've seen how to identify nutritional rickets. We've also seen that there could be a variety of kids who do not have nutritional rickets, meaning that they will not have frontal bossing, wrist widening, bowing of legs, or rachitic rosary. They may not have these features, but they may present with hypocalcemic seizures, tetany, or dilated cardiomyopathy, or osteomalacia. All right, so these could still be features of vitamin D deficiency without the characteristic features of rickets. And then you will have these vitamin D levels when you call them deficient, that is less than 12 nanogram per ml. When do you call them insufficient? Then they are between 12 to 20 nanogram per ml. So which variety should we treat? Who should we treat? 1. All children with nutritional rickets should receive vitamin D treatment. 2. Children with other symptoms attributable to vitamin D deficiency like hypocalcemic seizures, tetany, dilated cardiomyopathy, and having serum vitamin D levels of less than 20. So even if they're insufficient, but they have features which can be attributed to vitamin D deficiency, they should receive treatment. Third, if for any purpose in a healthy child, normally we do not recommend vitamin D levels measurement in healthy children, but for some reason you have sampled this child and his hydroxy vitamin D levels are less than 12 nanogram per ml, you need to treat. And there are certain group of children who are at high risk for vitamin D deficiency and who have vitamin D less than 20 nanogram per ml. So for example, children with nephrotic syndromes, children with chronic liver disease, children who are receiving steroid therapy, prolonged steroid therapy. These are children who are at high risk for vitamin D deficiency and its complications. In these children, even when they are insufficient, not deficient, even if they are insufficient at less than 20 nanogram per ml, we are going to treat them for vitamin D deficiency. See, I don't expect that you all will learn everything that I'm telling you, but at least you're getting primed. Go back and read these guidelines. You'll really remember a lot out of it. So these are doses for management of vitamin D deficiency. So there are two ways in which you can give vitamin D to a kid. Either you can give small doses daily for 3 months, or you can give larger doses at intervals for 3 months. Okay. So what is more physiological is daily doses. They say daily doses are more physiological, better absorption, and it is better to give. But what is the problem with daily dosing? Compliance. So for compliance issues, these weekly regimens or monthly regimens have been formed. So first, let us look at the overall doses. If you talk of less than 6 months, you give only daily doses. In less than 6 months, stress therapy, that is larger doses in one go, is not recommended because safety has not been established. Okay? So less than 6 months, no stress therapy. वो जो पहले देते थे ना 60,000 units, 3 lakh units, 6 lakhs, सब नहीं देना है. Less than 6 months, किसी को भी नहीं देना. ठीक है? So less than 6 months, 2,000 international units daily dose for 12 weeks. All right? And then obviously they're going to go to maintenance dose. Now between 6 to 12 months, either you can give again 2,000 international units per day for 12 weeks, or you can give an equivalent on a monthly or weekly basis. All right. Lastly, if the child is more than 1 year, you either give 3,000 international units daily for 12 weeks, or you can give 60,000 international units. सैशे आता है ना हमारा 60,000 इंटरनेशनल यूनिट्स का सैशे आता है हमारे पास एवरी 2 वीकली फॉर 5 डोजेस. ये याद कर लो आप सब. ठीक है, 60,000 इंटरनेशनल यूनिट्स एवरी 2 वीकली फॉर टोटल 5 डोजेस इन चिल्ड्रन मोर देन 1 year, because this is what you will be dealing with most of the times. Okay, so this you remember. And what we forget, what often residents forget, is vitamin. When you're giving vitamin D, you are supposed to give oral calcium supplementation along with that. All right. So an oral calcium supplementation in doses of 50 to 75 mg per kg, but there is a maximum capping of 500 mg per day. Should be prescribed. जैसे आयरन के साथ फोलिक एसिड है, उसी तरीके से विटामिन डी के साथ कैल्शियम देना ही है. ठीक है, while we are treating vitamin D deficiency. So this was as far as treatment is concerned, but how do we prevent again vitamin D deficiency? We want to prevent it. Some series in India are saying that almost 70 to 80% of our population is vitamin D deficient, which is like so large. So we have to prevent this, because again, like iron is not just iron deficiency, anemia, but so much more. Same way, vitamin D deficiency has been associated not just with the clinical features I have told you, but so many other things like predisposition to anemia, pneumonia, diarrheas, and asthma. So many studies are there. although nothing has come in guidelines to supplement such kids, but it is associated with so many more things. So it is obviously better to keep our population and our children replete. So routine vitamin D supplementation is recommended in infancy, 0 to 1 years of age, in doses of 400 international units per day. And most of the preparations that you'll get in market, vitamin D drops, 1 ml, 400 international units. All right. So you can prescribe that. So it is recommended. However, routine vitamin D supplementation is not recommended during childhood and adolescence. Beyond 1 year, they say आपको जितना vitamin D requirement है, it should be met from sunlight and dietary sources. All right, so you need around 400 to 600 international units per day, and this should be met from sunlight and dietary sources. तो कितना sunlight? ये कैसे पता लगेगा? किसी को पता है? Anybody knows how much sunlight exposure you need? Anybody? Anybody? How much sunlight exposure you should be receiving? 2 hours. Okay. I'll rather show you the slide. मुझे लगता है कि all right. So 30 to 45 minutes of daily sunlight exposure. ठीक है, 30 to 45 minutes of daily sunlight exposure over 12 to 18% of body surface area. तो body surface area कैसे पता लगेगा? ये next line में लिखा है मैंने. To maintain vitamin D levels in the Indian population. So and they say कि 5 times in a week ऐसा exposure होना चाहिए. ठीक है? So 30 to 45 minutes. Average आप 30 minutes लगाओ. 30 minutes of daily sunlight exposure to around 12 to 18% of your body surface area. 5 times in a week. Should be there. और timing कब है? 11 AM to 3 PM. कि ऐसा नहीं है शाम के 6 बजे जाके धूप ले रहे हो तो उसे धूप समझ लो. It has to be the typical sun between 11 AM to 3 PM. ठीक है? So this is the recommendation. अब रफ एस्टिमेशन ऑफ बॉडी सरफेस एरिया क्या है कि फेस जो है अराउंड 7 to 10% होता है, फोर आर्म्स 8% है, हैंड्स 4% है, लोअर लेग्स एंड फीट 8 to 12% है. ठीक है, 8% of body surface area, because this is probably going to be the only body surface area which is going to be exposed. तो आप अंदाजा लगा सकते हो, and this is how you give the sunlight exposure. And among dietary sources, vitamin D can be obtained from animal sources. So, जो non-vegetarian है, they can get fish, liver, cod liver oil, and eggs. While in plants, it is found in mushrooms, but majority of your vitamin D, it is going to come from your exposure to sun, where it is going to be synthesized in your own skin. So, what formulation of vitamin D to be used? Oral treatment with vitamin D is recommended. So this is what you wonder. You want to know whether we need to give parenteral or oral. So oral is the one which is recommended and is safer and is more rapid. So oral treatment with vitamin D is recommended, which is more rapid, which helps in more rapid restoration of vitamin D and is safer than intramuscular treatment. And आज की डेट में 3 lakhs international unit से ऊपर कोई नहीं जाता है. So पहले होता था ना 6 lakh तक भी दे सकते. Nothing like that is there anymore in the recommendation. 3 lakh is the upper limit, and that also I have shown you the table just 3-4 slides back as to how it is to be given. And there are various formulations of vitamin D available. तो आपको जो है polycalciferol ही देना है. ये alpha calcidiol, calcitriol, they are not recommended for management of nutritional rickets. तो आपका जो calcitriol है, ये तो आपका this is given in CKD patients जहाँ पे active conversion नहीं हो सकता. All right. So these all are not recommended for management of nutritional rickets. All right. Nutritional rickets के लिए जो आपके common preparations है वही देने हैं. All right. So how do you follow up these kids? Radiographs should be obtained at 4 weeks and at 12 weeks after vitamin D therapy to look for evidence of healing. So after you've given supplemented vitamin D for 4 weeks, you can get an X-ray done and you can see the white line of healing. And after 12 weeks, there will be should be complete healing. Most of the kids will show complete healing at 12 weeks. And at 12 weeks, you can also take the serum calcium phosphate SAP levels after vitamin to measure response and toxicity. Both of this I have taken from the guidelines only, which have been propagated by the IAP. So this was about vitamin D deficiency. Now very little overviews about a few other vitamins that we have. So there is something called vitamin A deficiency. So we all know about the ophthalmological manifestations of vitamin D deficiency, right? So that term which is used by this thing, WHO is xerophthalmia, and there is a staging which is given. So there's something called XN or nyctalopia, that is night blindness. That is the earliest manifestation of vitamin A deficiency that that a kid will have. So in the night, they'll start bumping into stuff and they'll not be able to see. And then progressively, they will have conjunctival xerosis, white hot spots, corneal xerosis, and eventually going into corneal scarring and fundus involvement also. I'll show you a few pictures in the next slide. Then there's something called follicular hyperkeratosis. So vitamin E deficiency can also lead to this trinodermia. It is called trinoderma, frog skin. See, can you see small papular lesions and extremely dry skin and slightly scaly rash? This is the trinoderma or follicular hyperkeratosis because it is occurring outside the hair follicles, just around the hair follicles. So this is follicular hyperkeratosis. It is being shown at the elbows. So this is follicular hyperkeratosis. And then you can have mucosal alterations because vitamin E is also involved in maintaining the integrity of the mucosa. So if there is mucosal alteration, it is going to lead to frequent gastrointestinal and respiratory infections. So eyes, skin, GI and respiratory infections. So look at this picture. So these are the bite or spot, the second stage. So you have night blindness as the first manifestation. Then you have the bite or spot. So this is happening on the temporal side. So outside, दोनों इस side पे आएगा पहले bite or spot, temporal side of the corneoscleral junction, and it appears like a white, chalky white, foamy patch on the conjunctiva. You can have corneal ulcer. So this is a stained corneal ulcer. They have used a fluorescein stain to make it more prominent. So it is present on the cornea. Then a progression of corneal ulcer. So this is keratomalacia, no? Corneal ulcer is keratomalacia. So this is happening. And then you have corneal scarring, which has occurred. So these are all vitamin A deficiency features. Now, who are the kids who are at vitamin A? So see, there are 4 fat-soluble vitamins, A, D, E, K. So any disease which is going to affect the liver, chronic liver disease and malabsorption syndromes, vitamin A, D, E, K are going to be deficient, right? Because the liver is involved in absorption of fat-soluble vitamins, courtesy the bile pigments and bile salts it is producing. So like that, chronic liver disease and malabsorption syndromes are a predisposition for vitamin A deficiency. And of course, you have children with SAM and measles, because measles decreases the absorption of vitamin A by as much as 30%. So that is why in measles, you're even giving prophylaxis for vitamin A deficiency. You would be giving in your hospitals and you would be knowing. So these are the populations at risk for vitamin A deficiency. What treatments you give? So for vitamin E deficiency, you give 3 doses, day 1, day 2 and day 14. How much is the dose? Less than 6 months, 50,000 units. 6 to 12 months, 1 lakh international units, and more than 1 year, 2 lakh international units. Okay. Then there is also the National Vitamin E Prophylaxis Program, where we are giving 6 monthly, 9 doses of vitamin A. And we start at 9 months of age when they're coming for measles vaccination, and we continue up to till 5 years of age. Dose is the same as that of treatment dose. All right. Diet, of course, we all know yellow fruits, mango, papaya. Then you have certain vegetables like carrots, tomatoes, and dark green leafy vegetables. These are the ones which are rich in vitamin A. Then quickly about vitamin C deficiency. What does it lead to? What is the name? What is the name of the disease you say when due to vitamin D deficiency? Who all is awake? Who all is still up? No, pellagra is not the name, Vita. Scurvy, yes, scurvy, yes. Yes. Okay. A lot of you know. So vitamin C deficiency is going to lead to poor wound healing. It is going to lead to gum bleeds. So why do this happen? Gum bleeds? Because vitamin C is involved in collagen synthesis, right? And collagen is something which maintains the integrity of your blood vessel wall as well as your skin. So whenever vitamin C is severely deficient, there will be poor wound healing, there will be gum bleeds. Then over here, you look at this. This kid actually had huge subperiosteal bleeds in the long bones. So it is a very painful condition. Apart from the swelling, they will not move their limb at all because it is very painful. That is why they have pseudo paralysis. So they do not have any muscle weakness, but because of the pain, they stop moving their limbs completely, and this is known as pseudo paralysis of Parrot. This happens in vitamin C deficiency, and like you have rachitic rosary in vitamin D deficiency, there is something called scorbutic rosary in scurvy. The difference is scorbutic rosary is not because of increased size of the costochondral junction, but because of the angulation that the ribs form. So they become more angled because they are weak, they become angled. And scorbutic rosary is painful, whereas rachitic rosary is not painful. So these are the, but vitamin C deficiency is far less common as compared to vitamin D deficiency. But if you do see such a kid, you should be able to identify. So who are the at-risk population? Okay, again, severe acute malnutrition and deprivation of citrus fruits. It might happen in some particular, it might be a cultural practice which leads to such vitamin C deficiency. Treatment is 100 to 200 milligram per day of vitamin C. Some say you can just have 100 ml of orange juice for 10 to 14 days and it is going to cure your vitamin C deficiency. And of course, in diet, what can you improve? Citrus fruits and vegetables like lemon and berries, and the light green vegetables like cabbage, cauliflower, and broccoli. These will provide vitamin C. Now, quickly about vitamin K deficiency. Vitamin K deficiency, you would all know, leads to bleeding manifestations. All of you would have heard about the hemorrhagic disease of the newborn. Mind you, it is not the same as hemolytic disease of newborn. That is different. That is mostly because of Irish IC immunization. This is hemorrhagic disease of newborn. Especially when people are given short notes, they confuse between hemolytic disease of newborn and hemorrhagic disease of newborn. Hemorrhagic disease of newborn is because of vitamin K deficiency. What will it lead to? It will lead to bleeding manifestations, usually in a neonatal period. All right. And 2 to 4 weeks is the common age. They can have bleeding from all sides. So, but deep site bleeds, muscle bleeds, large ecchymosis. They may have intraventricular bleeds. They may have parenchymal bleeds, brain parenchymal bleeds. And who are at the risk populations? If a child has received prolonged antibiotics or is on parenteral nutrition, or the child is again chronic liver disease. So I told you A, D, E, K are fat soluble vitamins. So in chronic liver disease, these will not be absorbed. And then you have cystic fibrosis. And if there is vitamin K deficiency, what do you expect? PT is going to be prolonged. Now, what is the diagnosis? You give vitamin, you do a PT, it is prolonged. You give vitamin K and within 6 hours, this PT is going to normalize to normal. PT value is going to be completely normal. So rapid therapeutic response to vitamin K administration is there. Of course, prevention is better than cure. So that is why at birth, all kids in all neonatal units are receiving vitamin K prophylactic dose at birth itself, and there are recommendations for supplementation in children with cystic fibrosis and CID for vitamin K. So that is about it. The key points are basically, I didn't really make an extensive key point list, but micronutrient deficiency is pretty common in Indian children. Almost 1/4 to 1/3 of our children have some form of micronutrient deficiency. So it is important for you to recognize those deficiencies and treat them. And thirdly, take all measures which are possible to prevent those micronutrient deficiencies, which is in a lot of cases is via our national programs which are running. So thank you. Doubts, a couple of them I took side by side, but I can take more if you have.
Thank you, Puneet, for such an extensive coverage, covering all the micronutrients, and that too with all the details necessary for practicing. I hope it was clear to all of you, and many of your queries got sorted out.
Thank you.
Congratulations to you.
Thank you, ma'am and sir. Yes, ma'am. Yes. Thank you, madam and sir, for this opportunity itself. It was lovely being with you all. Yes, ma'am.
I think some of you could not hear, audio was not clear. Don't worry, the whole session will be available on YouTube, NHSRC YouTube channel by Quality and Safety they call QSP. So QPS, sorry, QPS. It is available on YouTube. Siddhi, can you
Yes, ma'am. I'm
link?
sharing the link for
Yeah.
the
YouTube link here in the chat box, and also the post-test link. Meanwhile, both of them are here. If you still have some questions, you can ask. But I would request you to limit your questions to today's session. I know there were other related questions as well in the chat box. It's up to Dr. Dubey.
Very well done. I think very well conducted also. And Puneet also spoke very well and covered most of the topic, clinical as well as management part, and then practical tips. She has been asking in between also. So that is a very nice way of presentation. So I appreciate that. So I think we have
Thank you,
exceeded
sir.
just some
Thank you,
time, but
sir.
in any case, such an important topic and covered so well. So thank you, everybody. I think future also, whichever is very important topic, all of us should also try to join and attend it. Thank you, everybody. Thanks.
Sir, thank you. And you've been my teacher, by the way. So all that I've spoken is probably I've learned from you, sir.
Good. Thank you.
Thank you, sir. Thank you, ma'am, for the wonderful sessions on the nutritional deficiencies. We have posted, ma'am, there are some questions actually in the chat box.
Okay.
So, which formulation for vitamin D is better, chewable or oral, is one of the question.
So the recommendations mention only oral formulations of vitamin D to be used. Chewable versus orals are, there is nothing which is mentioned separately for the oral and chewable forms of vitamin D preparations in the guidelines. Honestly, I haven't truly reviewed about it also. So, Dubey sir, do you have any additional comments to make about this?
I don't think there is any comparison between chewable and oral. After all, after chewing, you also, swallow it basically, right? So it seems more or less they should be same. The only thing is that the taste may be a little different. Chewable maybe that the child may like, start chewing and then may like some more time, and the taste may be good. But I don't know. I don't think there is any comparison trial available, and should be more or less same.
All right. Sangeeta ma'am, your voice is not audible, ma'am.
There is no difference as such in the two formulations. It is just the matter of convenience, texture, and the taste which matters.
Right.
Which may matter to some, but the cost, you have to look at the cost of these preparations as well. You have to do both pre and post test. The pre-test link was disabled after the Dr. Dubey's session because we were halfway through the sessions. So that is why perhaps you were not able to submit. Post test, you can take it now. Otherwise, there is no sanctity if I keep the pre-test link open all the time.
Thank you, Dr. Sangeeta, and thanks everybody. Can I leave now?
Yes, sir. Thank you very much for
you,
joining us. We were enriched with your experience today.
And
Thank you.
please send me a link for the next topic and maybe the next webinar also. I would also like to join if it is of some interest in pediatrics. Thank you.
Sure.
Thank you, sir.
Okay.
Thank you, sir.
Thanks.
Thank you, sir.
Thank you. Bye-bye. Bye-bye.
Bye.
Yes, sir. Thank you, ma'am.
Puneet,
We,
thank you very much. Yeah.
Thank you, ma'am. Thank you. Thank
It
you.
was really wonderful.
Same, ma'am. Thank you. Thank you for the experience.
Yeah.
Okay, ma'am. I'll also leave then. Okay, ma'am.
I think you both answered all the questions. They are just doing
Yes,
the
ma'am.
post-test now. They will take some time to do it.
Yes, ma'am.
Thank you.
All right.
Dear participants, we have posted the post-test link. Along with the link, we have the feedback link. Kindly please give your valuable feedbacks so that we can improve our sessions. And also, I have posted the YouTube link. The session will be available on our QPS YouTube channel after 4 days.
One request to all of you, many of you are not giving feedback. Please do give us the feedback. You're doing pre and post test, but not giving feedback. That will also be invaluable for us to evaluate the entire program.